Hello, everyone. Good morning, good afternoon. My name is Achala Veerasinghe, the Director of Cultural Affairs at the Sri Lanka Foundation and Director of Operations at SLF Academy of Performing Arts. On behalf of the entire Sri Lanka Foundation, I would like to welcome our distinguished guests, our speakers, the outstanding medical professionals around the globe, from the US, UK, Sri Lanka, and Hong Kong. I'd also like to welcome you, our global audience, who are joining us from different time zones across the oceans, to our 7th medical webinar on COVID-19. I'm also very proud to announce that this is our first international medical webinar. Before we begin, let me go over our disclaimers. This webinar is provided for general information purposes only and does not constitute legal or professional advice. The information presented at this webinar is collected, incorporated, and provided purely for the convenience of the viewers and the general purpose only. The webinar hosts have made every attempt to ensure that the information has been obtained from reliable sources and the host is not responsible for any errors, decisions, or omissions of the information. The authors or the hosting company will not be liable for any claims, losses, or damages of any kind in connection with the use or application of any materials incurred due to the use of the information and material contained in this webinar. We thank you for your participation. And now let's hand over the webinar platform to our host, Keshini Vijayagunratna, the Director of Project Management and Public Relations, and our co-host, Chamod Amarasinghe, the Media Director at the Sri Lanka Foundation, who will be handling the tech work today. Thank you. Over to you, Keshini.
Thank you, Achala, for that great welcome and the introduction. I don't have to speak much now. You did my job. I will be very brief with my remarks due to the time factor. Before I move on, I would like to introduce my co-host, the Media Director, Chamod Amarasinghe. You have the video on, Chamod? Okay, great. Thank you, Chamod. Chamod actually is the creator for all the promotional materials and also handles the tech work. But I also have to recognize DG Studios that works with Chamod behind the scene with all the IT work. So you can see we have a great team that works behind the scene. Sri Lanka Foundation was formed in 2003 by Dr. Walter Jayasinghe. His mission is to keep the communities connected by educating and bringing awareness, especially during these difficult times. My heartfelt gratitude to you, Dr. Walter, also our President, Dr. Dishan Jayasinghe, and our Vice President, Aisha Jayasinghe, and for the entire Jayasinghe family for their dedicated effort to serve the communities worldwide. I also have to thank the 3 people that I work every single day, and we talk maybe 5 to 6 times daily. Without their support, I couldn't do this. That is Shirani Stanislaus, the Chief Operating Officer, Achala Veerasinghe, the Director of Cultural Affairs, and the Director of Operations for Academy of Performing Arts, and of course, Chamod, the Media Director. Thank you so much to all of you. Dr. Deepthi Jayasekara, the Medical Director of the Sri Lanka Foundation, you inspired me from the very beginning to plan these webinars. I don't know how to thank you, Dr. Deepthi. Without you, I wouldn't be sitting here, honestly. And we've gotten better because I got trained by the best. I am so honored to have had the opportunity of working with outstanding medical professionals the past few months. And today, we bring you a panel of doctors that have the utmost expertise and have studied in the various areas of the COVID-19 pandemic. This panel was thoughtfully selected by Dr. Deepthi, a medical director of the Sri Lanka Foundation. And you all are in for a worthwhile session. I have to mention another very prominent person in our community who promoted this event in a very large way with the very detailed news articles that he wrote that was published in US, UK, and Australia. This is none other than Nandi Jasuntuliana. I hope you're listening. Nandi, thank you so much for all your support and your advice that you have given me almost daily. Thank you. Now it is with great pleasure and honor I invite the founder of the Sri Lanka Foundation, Dr. Walter Jayasinghe, to speak. Dr. Walter, over to you.
First and foremost, let me welcome everybody, all the participants. We have a record number. Almost 375 people have registered, and I think they're all in already. And of course, the most expert panel of the panelists that have been handpicked and chosen, who are doing this as a great service to humanity. Dr. Deepthi Jayasinghe, our medical director, has spent hours working with the project manager, who is Kashini, get this thing on the road. So let me welcome everybody, our staff, panel, and the public to make the best use of this occasion. Thank you very much. That's all I have to say.
Thank you, Dr. Walter. You inspire us every single day. I'm here because of you. You challenge us, see, Dr. J. Seriously, I can see Achala smiling from behind the scene. Now I'm very honored to invite His Excellency, Ambassador Ravinatha Arya Singha, the Ambassador to Sri Lanka of the United States. Ambassador, over to you.
Thank you very much, Keshini, and Dr. Walter, and the panelists who are participating in this session, and all those joining this session from across the globe. First and foremost, I want to pay tribute to the Sri Lanka Foundation for taking this initiative in trying to keep the community both here in the United States and abroad, including in Sri Lanka, up to date on what the latest developments are in relation to the COVID pandemic. And particularly, I want to thank Dr. Walter for his inspiration given in all the work of the Sri Lanka Foundation, something which the Sri Lanka Embassy and the government of Sri Lanka is deeply grateful for. I've been wondering what ambassador and a diplomat has got to contribute to this wonderful panel of academics who know actually something about COVID. But I did think of at least two things. One is that when COVID first broke out, I happened to be the Foreign Secretary of Sri Lanka and had to deal with the early part of dealing with a crisis which no one knew the full magnitude of, particularly in the context of the large amount of expatriate Sri Lankans, both students as well as Sri Lankans working abroad who were wanting to get back home. And this brought some knowledge about the complexity involved in this, in dealing with something we at that time didn't know very much about. And I'm very happy to see Dr. Ananda Vijayavikrama here in this panel today, because it's people like Dr. Ananda Vijayavikrama and his team at the hospital, Infectious Diseases Hospital, together with people like Dr. Anil Jayasinghe, who helped President Gotabaya Rajapaksa and the government stabilize the country in dealing with the first wave of this pandemic, which we handled exceptionally well. Of course, the second is that I have got COVID and recovered, and also that I have now got my 2 vaccinations. We talk at a time when things are changing both in the handling of the crisis and also in Sri Lanka going through a more heightened anxiety, if you like, about the present wave. So this comes as in a good timing, both wherever you are in the world, because I know that the experts who have put together, and one I know personally very well, Dr. Deepthi Jayasekara, whom I know has spent a lot of time on this. In a previous discussion, somebody called him the, what was it, the Fauci of California or something similar, has spent a lot of time. So I don't want to take any more time. The Embassy of Sri Lanka is very grateful to all those Dr. Altam, Dr. Piris, Dr. Jayavira, and Dr. Senaviratna for participating in this session. And I want to thank once again the Sri Lanka Foundation for putting this together. And I look forward to benefiting from the new knowledge which this is going to give us, and something which I think we should all keep ourselves updated about going forward, so that we deal with this problem and get on with it, life and not letting it get to us. Thank you.
Thank you, Ambassador. On behalf of the Sri Lanka Foundation, I would like to extend a warm welcome to the new Consul General to Los Angeles, Dr. Lalit Chandradasa, and invite Dr. Lalit Chandradasa to speak.
Good evening, everybody, or good morning. It's my pleasure to be able to meet you all today. And Dr. Walter Jayasinghe, the Sri Lanka Foundation, organizers, and the panelists. I think it is a very crucial time at which we are having this. In this country, I think certain states are now experiencing again a bit of numbers are going up. And in my country, or Sri Lanka, things seems to be again getting out of hand. So at a time where we thought everything was under control, again, various queries come into our minds. In fact, very recently, I think about 2 or 3 days ago, there was something to say that it is not only droplet infection, but the virus can be carried even by air. Again, nobody knows about it. And when it, treatment, of course, I think we are fairly okay, but there are new variants. Again, we are not sure whether the vaccines will be able to control it. And personally, I have a problem. I think the panelists will try to help me, because when I came from Sri Lanka, I got the first shot of AstraZeneca. Now, for me to get the second shot, AstraZeneca is not available here. I don't know what to do. I'm trying to find out. I hope, like me, there are a lot of people who have doubts on various things regarding the disease. So, and the vaccination. Will the Pfizer have to be given annually, or whether it is effective only for 6 months? So I think it's the best time, the correct time for the Sri Lanka Foundation to have organized this webinar, because if not all, at least most of the, I think most of the doubts we have can be solved at this webinar. So thank you very much.
Thank you, Consul General. Last but not least, I would like to invite our Vice President, this is Aisha Jayasinghe, to say a few words.
Hello, everyone. I'm Aisha Jayasinghe. I'm part of the Sri Lanka Foundation International. And I want to welcome the panelists for all their dedication and time spent preparing and also giving us vital information that would help us on the ongoing problem of COVID-19 and all the differences that is happening, the changes that are being made. So we are very delighted that you are able to come and help us and teach us some more about the COVID situation. And I also want to welcome the people that have tuned in to this webinar. They are from all over the world and are from Sri Lanka. I want to welcome you all. I know we are going to learn a lot. We have wonderful people who are trying to teach us and make us confident that things will get better and we can help who can help us best. Thank you very much.
Thank you, Anisha. This is the moment you've been waiting for. Now I hand over the webinar platform to Chief Operating Officer Shirani Stanislaus to introduce the panel of doctors. Over to you, Shirani.
Good evening, good morning, and good afternoon. My name is Shirani Stanislaus, the Chief Operating Officer of Sri Lanka Foundation International. Welcome, everyone. Today, I have the pleasure of introducing 6 eminent physicians who are specialists in infectious diseases and viruses. Due to time constraints, I will not read out all their qualifications and accomplishments today. First, I would like to introduce Dr. Deepthi Jayasinghe, MD, FACP, MIDSA. Dr. Jayasinghe is the Medical Director of Sri Lanka Foundation International. He's a board-certified infectious disease specialist who has well over 25 years of experience. Serves as the Chair of Infectious Disease at Emanate Health Hospital, San Dimas, and Kindred Hospital, Baldwin Park, California. While being engaged in a busy clinical practice, he volunteered his precious time to serve the community in general. As the Medical Director of Sri Lanka Foundation International, he was instrumental in organizing many Zoom webinars to educate our community on COVID-19 and other matters. Our next speaker is Dr. Dushanti Jayavira. Dr. Jayavira is a professor of clinical medicine at University of Miami, Florida. Currently, he oversees the infectious disease clinics at their Miller School of Medicine, Jackson Health System, where over 3,200 HIV patients are managed. He's one of the lead investigators in the Miami Clinical and Translational Science. Next, I would like to introduce Professor Suranjit Senaviratne. Professor Senaviratne is a professor and consultant at Clinical Immunology and Allergy, Institute of Immunity and Transplantation, Royal Free Hospital at University College, London, and Health Services Laboratory, London. Also at Navaloka Hospital Research and Education Foundation, Sri Lanka. Professor Senaviratne is an international expert in immunodeficiency, autoimmune allergic mast cell disorders, and immunogenetics. He is the director of the Center for Mast Cell Disorders and the president of UK Sri Lanka Immunology Foundation. Our next speaker will be Professor Malik Piris. Professor Piris was a Lifetime Achievement Award winner of Sri Lanka Foundation International in 2018. Very nice to see you again, Professor Piris. Professor Malik Piris is a clinical and public health virologist in emerging virus disease at the animal-human interface, using a One Health approach, including influenza, coronaviruses like SARS and MERS, and others. His current research encompasses the pathogenesis, innate immune responses, transmission, ecology, and epidemiology of human and animal influenza viruses. Currently, he's researching the recent emerged MERS. Our next speaker will be Dr. Paul Holtam, MD. Dr. Holtam is the Chief Epidemiologist at USC Keck School of Medicine and Professor of Infectious Disease and Internal Medicine, USC Keck School of Medicine. He's an infectious disease specialist affiliated with Keck Medical Center, USC, and University of Southern California, Norris Cancer Hospital. He has over 41 years of diverse experience, especially in infectious diseases. As an internist, Professor Holtam specializes in the primary care to adults through diagnosis and treatment of cross-system illnesses that may affect multiple organic systems. Our final speaker will be Dr. Ananda Vijay Vikrama. Dr. Ananda Vijay Vikrama is a consultant physician at the National Institute of Infectious Diseases, IDH Colombo, Sri Lanka since 2003. He's an external lecturer, examiner in faculties of medicine and member of the National Medicines Regulatory Authority of Sri Lanka. His postgraduate training included dengue, SARS, avian flu, and other emerging infections, and HIV. He won the ProMed Award for Emerging Infectious Diseases in ICID in 2016. Thank you and enjoy the presentation. Now I will hand over the webinar platform to our moderator, Dr. Deepti Jayasinghe.
I'm truly honored, truly privileged to have all you guys on this panel. This is the very first time we are organizing a international webinar involving the elite of the elite, infectious disease and immunology specialists who have contributed immensely to different fields, including COVID-19. Anyway, thank you very, very much for agreeing to volunteer your time to present or give us what you know, share with us what you know, your experience, your expertise. But first of all, I'd like to thank Walter and Aisha and Keshini, Chamod and the team for giving me this opportunity once again. We are still in the middle of a pandemic, as you know. We actually kind of basically shifting the epicenter of this pandemic from place to place now. As you know, we have about 60,000 cases in the United States, whereas a country like India is reporting 330,000 a day. Every 5 minutes, there's a death in India, sadly. And then most importantly, there are mutants. There are triple mutants. There are double mutants. We need to know all these things because if it's India now, it could be Sri Lanka tomorrow, right? And all this time, India kind of after the first wave, they kind of relaxed their protocols. They were found to be very complacent, and we knew this all along. They didn't even require a quarantine protocol for returnees to India, which is very bad. Because now what's happening is all these mutants, including B117, B351, P1 from Brazil. So B117 is from UK. That's a UK mutant. B357, 351 is from South Africa. And then P1 from Brazil. And then there are newer variants now that kind of combine together. So there are double and triple mutants, and those are called B617 and 618. Actually, it's 1617 and 1618, which are rampant in India. Much higher level of virulence, much higher level of contagiousness, and then much more deadly than the rest of the virus. So we're going to talk all about this and more with the help of these panelists. And thank you for Shirani for the lovely introductions that you gave us. I'm going to dive right into the first speaker for knowledge and wisdom. Our first speaker is going to be our own Dr. Dushanta Jayavira, who's a professor of medicine at University of Miller School of Medicine, University of Miami. He has been in the forefront in research there, HIV, as well as regular infectious diseases. In fact, he's very well known for being a PI of the Johnson & Johnson vaccine. So he can tell us all about Johnson & Johnson vaccine and what we are going through with that vaccine. Not only that, he's going to talk to us about the therapeutic advances, the treatment advances of COVID-19. Over to you, Dushanta.
Thank you, Deepti. Again, I want to thank Walter and the Sri Lankan Foundation for inviting me to speak. And so the charge today for me is to talk about the therapeutic aspects of COVID-19. And I'll get into that straight away because of the time constraints. So my objectives of today's would be more about the life cycle. I'm not going to go into detail because there are much better speakers and much more knowledgeable people on basic science, Malik and others who will speak about these things. I will, most of the time, I will be talking about what you shouldn't do rather than what you should do. So, and I'll briefly review about the the clinical trials landscape. And I'll talk about the NIH guidelines about the corticosteroids, remdesivir, convalescent plasma. The monoclonal antibodies will be covered by Dr. Paul Holtum, and the COVID vaccines will be covered by Suranjit Seniviratne, so I won't touch it. But briefly, I will speak about Johnson & Johnson because I've been working with them, and but I will not go into too much detail about other vaccines. So as you all know, this COVID-19 has this kind of the time duration of the time scale, where from the time of exposure to development of symptoms, and at what time the PCR comes positive or PCR comes negative. So this is basic information. I think we have known this for almost a year, but I just put this to show you that you should get a positive test before the symptoms come. But once the symptoms come, you should get a positive test. And interestingly, the fecal tests tend to last longer, and that's of special interest because University of Miami is trying to do a prevalence of COVID by looking at wastewater COVID excretion. So just to touch upon the symptoms, these are, I'm sure everybody knows, and unless you were under a rock for the last 1.5 years, I mean, you have these headaches, the cough, the usual respiratory symptoms, which happens from 2 to 14 days after the exposure. And these are classic symptoms. The most of my patients have real fatigue and muscle pain, but eventually they develop shortness of breath and headache and nausea and vomiting and GI symptoms. But what is interesting is that we are seeing more and more patients coming with extrapulmonary manifestations, whether it be the dermatologic or cardiology, endocrine, GI, and you can see the whole plethora of symptoms or the diagnoses that people will present with in this condition. So I'm not going to go into detail, but the reality is that there is significant amount of mortality and morbidity occurs because of these complications. So when this happened, as the ambassador said, we were almost in a panic mode. I mean, I remember that we didn't, I mean, not only that we didn't know much about the disease, perhaps Malik knew a little bit more, but we didn't know any much about disease. We were not prepared for isolation. We didn't have lots of things that we should have had. I mean, for a well-resourced country like United States, it was embarrassing that we couldn't find swabs to collect samples or the transfer media to get it to the lab. So having that history, so this is the kind of the people were all over the place trying to develop drugs or repurposing drugs. We were using every drug development therapeutic platforms that we normally use to come up with repurposing drugs. And this is what happened. So early on, we recognized that the virus enters through the ACE2 receptors using the spike proteins. So we were looking for drugs that will block that. We knew that there was, this was an RNA virus, and there was a polymerase that causes viral is used in viral replication. So Gilead quickly came out with remdesivir, and other companies came with favipiravir, and ribavirin was repurposed. And by the way, the remdesivir was developed for Ebola. So, and then of course the hydroxychloroquine story, you know, it's already shown here. During the viral life cycle, it blocks at different sites. I'm not going to go into too much detail because that's not that important, because what's important is what can we do. So in this madness of trying to come up with the drugs, we started from nothing to almost 2,800 clinical trials to be done were done within like 11 months. And it's interesting, this was from the ct.gov done by the NIH and the FDA, and the slide credit goes to them. We realized that they were into different categories. There was the antivirals, the immunomodulators. That is because we recognized that there was a cytokine storm, which led to great mortality. So if we want to block it, there were neutralizing agents like neutralizing antibodies, which we knew that was going to help in the absence of a drug. Especially it worked in Spanish flu, so we thought, that might work. And of course, a combination. But the real tragedy was that most of the studies were not powered enough to give an answer. So the question is NIH is asking now, what you, as you know, the National Institute of Health, why did we go wrong? It's a multitude of things. The main issue is that the funding. The main issue was the funding, because at that time there was not enough funding to come to each investigator or researcher, or even the NIH institutes didn't have enough funding from the government to increase the sample size. The second, of course, miscalculations. I'll get to that later. But eventually only 5% of all these studies were powered to enough to answer a question. It was a huge waste of resources. So if you looked at all these diseases, all these drug trials that were going, you could slot them into different phases. The early infection, pulmonary phase, and hyperinflammatory phase. So what we tried to do was to come up with regimens which will slot into each of these stages, so that we could, the whole idea was to prevent mortality and morbidity, and try to keep this thing going as long as we can develop better agents. So the initial, the stage where early infection, mild constitution symptoms, we didn't do very much. We didn't have any agents except just manage. Some people gave vitamins D and E, and there was no clinical trials to show any of this would work. But there were sort of, ideas that it may work due to theoretical possibilities. One of the things that we learned very early is that these theoretical possibilities never worked. There were so many, especially good example was hydroxychloroquine. I mean, there were theoretical possibilities that it has an antiviral effect and an anti-inflammatory effect, but none of this worked. So it taught us a lesson that not to go by the machine learning algorithms that we put into our systems to come up with the repurposing of agents. Sometimes they don't work. The second one was the pulmonary phase, where remdesivir seems to work. That again works in a very specific population. So when people think that remdesivir is answer to all the problems, it's not. It's a very specific look. I'll come to that later. And eventually, of course, the hyperimmune phase. Dr. Horton will be talking about more of these cytokine blockers and monoclonal antibodies. So initially, when the pandemic started, we had our regular meetings every day. And one thing that's absolutely clear, but that good ICU care, that's what saved lives, just good ICU care. And I'm sure that's why mortality in Sri Lanka or US and any other places were good, where there was good ICU care. In fact, I'm doing the convalescent plasma study where we are comparing Miami, Yale, NYU, I have a slide on that, with Texas. And I think we have a pretty good ICU care, where the mortality rate was lowest at the University of Miami compared to all the sites, because I think we had a pretty good ICU care. So what the WHO and the NIH states is that there are basic fundamental principles you have to follow. We know that there is increased thromboembolism, so you need to monitor them and anticoagulate them. That was given, that we realized that very early. There has to be that, make sure that there are no infections. You have to turn people every 2 hours and, make sure that their nutrition is okay, so that their albumin and all the parameters are maintained. Use antibiotics judiciously. Don't just throw antibiotics at everything. Don't panic. And of course, consider about the drug interactions. And we recognize that you have to provide ventilator support, use low tidal volumes, do proning 12 to 16 hours a day, practice conservative fluid management, and consider ECMO, which is extracorporeal membrane oxygenator, if there was no response. So this is all basic ICU care. This is what you do every day if you're an ICU physician. And so this actually what really saved a lot of lives. Then, of course, if we learn that minimize sedation and maintain semi-recumbent position, and again, as I mentioned, that baseline good ICU care. So that alone saves life once you get to that stage. Then comes the corticosteroid story. Now, when you know about corticosteroids, we all have been using corticosteroids in ICU for ARDS. And so when COVID-19 started, this recovery study, which was done by WHO, it's a kind of adaptive design with multiple arms, looking at, compared to the placebo, what are each one of these different agents, how they respond. And in June 8, 2020, recruitment to dexamethasone arm was halted because sufficient numbers were enrolled and to establish a potential benefit. So that was good. That was good. But of course, we knew that. I mean, of course, but you need to do a study. So if you look at this Kaplan-Meier plots, mortality versus duration, and you can see the usual care had a higher mortality quoted dexamethasone with a p-value of 0.001. But if there's no oxygen therapy, there was no statistical significance. So that just told us that, you know, this works when the people are a little sicker, which came back to again, then that if the patients want invasive mechanical ventilation, then the steroids work very well. So now we have established that the steroids would work in people with COVID-19. There was nothing to talk about. So NIH and the IDSA comes up with these guidelines. So IDSA says people who are hospitalized with critical COVID-19 recommends use of dexamethasone. And then the dose is given. And NIH goes a little further, that they are a little bit more liberal. I mean, basically, they comes back with the same point. So I don't want to labor that too much. I'll come to the remdesivir later. So then comes the remdesivir. As you know, remdesivir is a nucleoside analog. Gilead is very good at developing nucleoside analogs because they have developed, I mean, plethora of HIV nucleoside analogs for HIV treatment. It basically blocks the inhibits. It's a competitive inhibitor, and it makes the delays the chain time, cause the chain termination, competing for ATP as an analog. So the study that was done was again an adaptive design, looking at remdesivir as placebo, and it's interesting. These studies they were running on an 8-point ordinal scale. And when you really try to do this ordinal scale, it's not a really easy scale to do because there's a lot of difficulty in interpreting slotting them each one into the scale. But bottom line is that this study, Act 1 with NIAID, showed that the median time to recovery got shorter if you use remdesivir versus placebo with a p-value of 0.001. So, which is actually good. And then the side effects were fairly modest. You know, they have some liver problems and the kidney problems, but nothing to write home. So the real issue here is that the remdesivir actually works only if the people who are receiving oxygen who are not too sick. So you have to catch them early, not too early, not too late, right in the middle. So it is possible that this drug would have not been approved in any other condition. Or if they repeated this a few times, it is very likely that this drug will not be approved because of the very, very marginal benefit of remdesivir. So then comes the convalescent plasma. I mean, I just completed a 1,000-patient study. I was the PI for Miami. I just mentioned that with NYU and Yale and Texas. And that's another long story. So as I mentioned at the beginning, that I'm going to tell you what not to do more than what you should do, because it's very important that we have a very scientific basis of what we are going to do. So fundamentally, when you give convalescent plasma, what you're doing is you give passive immunization with neutralizing antibodies. So if you take, I mean, you can give neutralizing antibodies as monoclonal antibodies, which Dr. Halton will be talking about. You can give hyperimmune immune globulins derived from plasma again, or you can give convalescent plasma, which we get many studies, which is interesting. So this is the fundamental principle how this happens. You take the blood, you separate the plasma, and then you turn it around and infuse the person. You can give 1 unit, 2 units, but what's important is that they should have a high plasma titer of neutralizing antibodies, at least 1:320 or 1:160. You need such a high antibody titer. And this is a study from China which showed that it works in some populations. It's in the severe disease, not life-threatening, not early, but severe disease, but not life-threatening. It works. The sooner you give, better it is. And so that was one of the hypotheses. So at that time, when we were first designing studies, there was an interesting study that came from Amsterdam, which we never listened to. I was at the NIH conference when they presented this. They ran a study where they compared convalescent plasma with standard of care. The study was stopped halfway through because they found that the people they were infusing, the patients, already had neutralizing antibodies at almost 80%, similar to what you were giving. So the question arose, why are we giving convalescent plasma if the person already who is infected having enough antibodies? And again, this showed that there was no clear benefit by giving convalescent plasma in the COVID, but we didn't take it seriously because we thought that we were right, and we ran studies. So I was the PI for this for Miami with the NIH. Large study, 1,000 patients infusing, and we have just closed the study. We are analyzing the data, and we still don't have the data. I'm keeping my fingers crossed, but so it's possible. It is possible that this study may show that there is not much benefit, but the data has to come out. I have to wait. So obviously, the FDA, in its frustration and anxiety with what to do, they gave EUA for the use. And with caveats, there are theoretical risks of antibody-dependent enhancement, and of course, potential adverse events, and the providers have to be careful. And one of the questions that people were asking were that if you gave convalescent plasma, would it push the virus towards developing more variants, for the virus to mutate? As you know, the more selective pressure you apply on a virus, the greater the chance that the virus will mutate. I'm sure my other colleagues would talk about this more in detail. And Tony Fauci was touting this because, obviously, that was the idea at that time. We spent $800 million giving convalescent plasma in the United States, and the program is fizzling out. And this is coming from our great medical journal, New York Times. We infused 722 units of plasma, and we made a huge mistake by giving Mayo Clinic sole authority to just give it away, and that blocked our ability to do research. So now I'm going to briefly finish my treatment. So as I said before, hydroxychloroquine does not work. People tried lopinavir, ritonavir, ivermectin. None of those really worked. Ivermectin maybe, because there was a study from Colombia we just presented, it didn't show a difference. But if it's a larger sample size, perhaps it may work, but it's not recommended. So the drugs that are recommended by the NIH guidelines is that people who are not hospitalized, mild to moderate, you can give bamlanivimab and etesevimab. The most difficult thing about this is how to pronounce these words. Otherwise, my tongue falls into my throat. If it's high risk for clinical progression. So this is very important. Just because somebody gets COVID, you shouldn't be giving this. Only for high risk. And there are certain criteria that you have to meet. You have to be over 65, you have to have comorbidities, you have to have obesity. There are certain criteria, but not hospitalized. And of course, you must not use dexamethasone early because it doesn't work. And And then, of course, these are the things that I mentioned about, BMI should be more than 35, chronic disease, and yeah, we mentioned that. And of course, if they are hospitalized, require supplemental oxygen, but not high flow or vent or ECMO, then you choose remdesivir or remdesivir plus dexamethasone or dexamethasone together. So these are the basic things we do. You can't use this remdesivir once there's no point in using remdesivir, paying almost $60,000 to if a drug doesn't work, if the patient on a ventilator. So this was the final treatment that recommended. I mean, I know a lot of people do all kinds of things to treatment, but none of them have been approved nor they validated by any agency like FDA or the EMA. So now I go to the Johnson & Johnson briefly. I'm not going to talk much about because Suranjit is going to talk all about vaccines. I'm going to briefly talk about what went wrong with Johnson vaccine. As you know, there were we enrolled close to about 400 some subjects in Miami. And obviously it's only a small fraction of the entire total population of 41,000 people enrolled. And then the first report came in the clinical trial where cerebral venous sinus thrombosis was detected in one patient. And we had a small pause in the study, during the study, which was later described by Johnson. And it was, if you look at the whole picture of cerebral venous sinus thrombosis, it's very rare. It's very rare, 0.2 to 1.57 per 100,000. And of course, the risk factors, as you see, pregnancy, oral contraception, malignancy, the usual stuff that leads to thrombosis. So this was the timeline. So the emergency use authorization was given for the vaccine on February 27th. We started the study somewhere in roughly about end of August. So the study ended recruitment in the middle of January, end of January, and then the data was analyzed and it was presented to the FDA and EUA was given. And then the vaccination starts on March 2nd, and April 13th, the study puts a pause because of 6 cases of thrombocytopenia. And now, of course, yesterday the study was, the vaccine was again reauthorized. So if you look at the broad picture, 6 cases out of 6.86 million doses, it's nothing. It's 1 in a million. It's 1 in a million, and it's hard. There was no deaths, and if you drive cars, 40,000 deaths a year. So that means that you're not going to drive cars? No. So that's why the FDA approved it. So to be honest, that Pfizer didn't have a single, and Moderna had 3 reported cases with normal platelet count. So these are the New England Journal publications that came out within the last week, which basically stated that these were validated, that this was this is from AstraZeneca, but because they are both adenovirus vectors, that this is clearly a vector-driven issue. So the characteristics of these are that out of the 6 patients, they were all, the median age was 33. The median time to symptoms were 8 days. They were all white females. Only one was on estrogen or progesterone. One of the cardinal factors was the platelet factor 4 heparin-induced antibodies was present in 5 out of 5. So platelet factor 4 antibodies. So this is one of the things that you have to test if somebody comes with similar symptoms. And the other things didn't really matter in this group. So when you look at the treatment, how the people were treated, 4 people were treated with heparin, which we shouldn't be doing. If you have these platelet-associated antibodies, you should use a non-heparin anticoagulants. So the people who use heparin were probably used at the beginning before they knew that this was associated with PF4 hit antibodies. And there was 1 death. Sorry, I made a mistake. There's 1 death. So in summary, we are very careful now. I mean, we are following our patients, and we are carefully looking for headaches, backache, any of these neurological symptoms, and then we start screening them for factor 4 levels, and we work with the hematology team in case one of these comes. These things happen all the time. They're not I mean, people will come with headache, but you have to take it seriously. So, but I don't think that this is a problem that we should be worried about. And I want to reassure the population that Janssen vaccine is safe enough to be taken. I have given it to my wife, I've given it to all my friends, and everybody has taken in Miami, and it has been fairly safe. So what FDA says is that it should be resumed. It was released yesterday. It's safe and effective. The data shows that there's a potential benefits outweighs the risk. Not even a warning between 18 and 50 for women. It's just that you need to know that this is the possibility, that you should understand that there are risks involved in anything. But altogether, it's a very safe vaccine. With that, I will stop, and I would like to thank Walter and all my colleagues and these are my disclosures, and thank you.
Excellent talk, Dr. Jayavira. And we learned a lot, as always, right? So simply speaking, Johnson & Johnson vaccine is a very, very good vaccine. It's actually a great vaccine. It's given in one dose, and there's no cold chain requirements, right? So
absolutely,
you can keep these vaccines for up to 2 years, they say, yeah. Right? And then not only that, efficacious, right? When Johnson & Johnson trials were going on in South Africa, it was still much better than AstraZeneca efficacy. Can you believe that? So yeah, it's a great vaccine.
Yeah, I didn't want to talk too much of vaccine because Suranjit is going to speak about it. So I left it to Suranjit.
Sure. Over to you, Suranjit. Now, Suranjit is a professor of immunology from England. He's an Oxford-trained graduate from my own medical school, Colombo Medical School, medical faculty. And he's going to talk about different types of vaccines, their efficacy, their safety numbers, and other details. Suranjit, over to you.
So thank you very much, Deepthi, Keshini, Dr. Walter, who I have to mention that he treated me as a child when I was in Sri Lanka, when he was in Sri Lanka long ago. And that was a great coincidence. And thank you very much for Pramod and for everyone for inviting me to give this talk at this session. So well, if you look at this slide, what it shows basically is the sort of the number of cases, the actual number of cases in the world as of yesterday in UK, US, and India and Sri Lanka. And immediately you can see that the number of cases and the number of deaths have been very, very high in certain countries and lower in other countries. But the important aspect to consider there is that Sri Lanka has controlled it beautifully. But now the important thing is not to go have another sort of wave coming in, because this condition can change at any time. And as we see the picture in India, that can happen at any time. So basically, if you, these are some of the sort of papers that we have written, and it's a respiratory disease. However, other organs can be involved. Previously we said atypical, but we know that these are quite important at the present moment. And the reason I put this slide was importantly to tell you that coagulation, which Dushant beautifully explained with regards to the J&J vaccine, coagulation is a big problem when it comes to COVID. And we must not lose sight of that, because the risk of coagulation is so high in a patient who has COVID. And we have explained that in the sort of review that we wrote in hematological aspects of COVID. And that must be taken into context when analyzing or when describing issues with regards to any vaccine, because the risk is so high in patients with COVID per se. So vaccines have been one central pillar when managing this pandemic, which is going really haywire right around the world. 7 vaccines have been approved. And the important thing to remember is that 4 vaccines failed, because the sort of tendency to think in the community is, vaccines developed very soon, everything was accepted. No, it was not accepted. Australian vaccine, many other vaccines did not succeed. And 7 were approved, have been approved so far, and another one should be approved very soon. A lot of vaccines have been given. This is in millions. Clinical trials was in thousands. We are getting into over 500, 600 million. US has been leading the way with China, but a lot of other countries are following suit. And so my next slide shows the comparison between the present status and just 1 month ahead. You can see the pace at which vaccines are being given around the world. In the UK, we find that close to about 33 million first doses have been given, and many people have got the second dose too. And if you look at this, you know that Israel has the highest number of cases per 100,000, highest number of vaccines per 100,000. And several other countries are following suit and trying to vaccinate their population as soon as possible before variants come in and increase the amount of transmission. There's one important thing to remember, that vaccine hesitancy, and people, we do need to answer questions to patients with regards to vaccines, because the issue is that if people don't take the vaccines and they don't understand it, then that can be a problem in the vaccine rollout program. And if you look at this slide in the US, if a person is asked today, would they consider vaccine, the rate is lower than a place like the UK, where a person would accept the vaccine at the present moment. And this is something that the authorities are looking into and working, because if you want to get that situation of herd immunity, that is something that we should have as many a person vaccinated with these safe vaccines. So what I'll do in the next few minutes is quickly give you an outline about the basics of immune response. The variants would be discussed by Professor Malik, and then talk about some of the vaccine effects that we have seen. So if you look at the immune system, you have the innate immune system, adaptive immune system, you have B cells making antibodies, and you have white T cells which are important, CD4 and CD8 T cells. So you have the innate immune system and the adaptive immune system. Now, the important aspect to remember with regards to COVID is, in people who get severe COVID, you have a problem with the innate immune system. The recognition of the virus and the immediate response is not good. And this was a paper published in October, which showed that certain people have viral sensing defects, and quite a few other studies have been done in this aspect. And there is about 10% of people with severe disease who have antibodies against interferon. And that's an important aspect to remember, that the innate immune system may not be working properly. And we would try to take some step to sort of negate this effect and to be able to get the person to mount a proper immune system. We have antibodies, IgG antibodies, IgM antibodies, we have CD4 cells, we have CD8 cells. These are important components of the immune system, which comes after an infection. And also what we're trying to do with vaccinations is trying to get it pre the person being exposed to SARS-CoV-2, so that they would not run into problems and they will be able to fight the infection. If you look at the antibody response, this is the sort of pattern we see. It develops very early and then it persists for quite some time. And the recently published Siren study showed that it is quite effective in preventing reinfection of the person. So these are working. After natural infection, you find that the antibodies are working and preventing infection in addition to the CD4 cell and the CD8 cell. This study was published about 3 days ago. So when we look at the T cells, we have both CD4 cells, we have CD8 cells, and you can see that it recognizes different parts of the virus. It's not only the spike protein, which is targeted with the vaccination, it recognizes a whole number of proteins on the virus, and you get quite a broad sort of response seen in patients who are exposed to SARS-CoV-2, and people, the expectation is that we get a good immune response in patients who get the vaccine too. An important thing to remember is that as you go older, your immune response is poorer, and therefore the innate immune system doesn't work properly, the adaptive immune system may not be working efficiently, and therefore the person can be having a delayed response with regards to the CD4 and CD8 cell, and they may not be able to control the virus. There are studies going out to 8 months, and this is a study showing that after a natural infection, you have the CD4 and CD8 response lasting up to 6 months. This was a study up to 6 months. And then you have different memory responses, which was beautifully shown by the San Diego row. That's B cell memory with the antibodies being produced, antibody memory, and T cell memory being there to protect the patient. And it goes out to 8 months. So therefore, you get a robust response post-infection. The people who don't make a good innate immune response or a cellular response get severe infection. And the important thing to remember is that with vaccination, what we're trying to do is mimic that as best as possible. This was the schematic that was produced by the group in San Diego again. If the innate immune system doesn't work, as shown in the low diagram, the innate immune system doesn't work properly, then you find the viral load increasing, the antibody levels increasing, but the cellular response, that's the CD4 response, being very poor, and therefore the person getting very, very severe infection. And an important thing to remember is when it comes to eye patient, the patients I manage, the question is, we have a lot of primary immune deficient patient, we have a lot of secondary immune deficient patient getting steroids, getting other antibodies, monoclonal antibodies for different autoimmune diseases. The question is, what will happen to their disease? Should they be vaccinated? Is the vaccine effective? They should be vaccinated, definitely. Would it be effective? They may need more boosters. And would they get more severe disease? Certain groups of patients do get severe disease. And this was the publication we came up with from the UK, showing that certain immune deficient patients can be getting more severe disease. And that is a group that you have to look at carefully and vaccinate them early. And probably give more boosters depending on their response because of the fact that they can go into very severe disease. So just 2 slides because Prof. Malik will speak about this in quite detail. We know that viruses mutate, they change. Some of them have no consequence, some become more dangerous and more transmissible, and RNA viruses mutate more rapidly. There are 4 important mutants that we are variants of concern that we have at the present moment, and these are the sort of variants that are quite important: the UK variant, the South African, and the Brazilian variant. And now we have the Indian variant coming, and a whole range of other variants, which Prof. Malik will go into great detail in his talk. Why did I speak about this? Because it's important. Came to head when the number of cases in the UK rose rapidly from November onwards, and this was due to the UK variant, and it has implications with regards to vaccine responses, etc. So now I'll just go into the main hub of the sort of talk. We know that there are several vaccines. People have written about it. It's against a spike protein that's found on the surface of the virus, and these are the properties of 5 of the vaccines that have been approved so far. You can see that most of them are 2-dose vaccines, and you should get 2 doses. If you have to get a 2 doses, it's a 2-dose vaccine. J&J vaccine is a 1-dose vaccine that is very helpful in many settings. The Novavax vaccine should be approved quite rapidly. The efficacy rates are given in this slide, and the cost is different because certain vaccines are very cheap while other vaccines are more expensive. Now, an important thing to remember, as at the present moment, if you get AstraZeneca vaccine, you should get an AstraZeneca vaccine at the second moment, but there is a big vaccine shortage, and studies have been done about mixing vaccines, and that may be the way the world will go with regards to some people receiving AstraZeneca and then secondly getting in certain countries, it's a Gamaleya vaccine, the Russian vaccine, or in other countries, them getting the Pfizer or the Moderna vaccine, and those studies are being done at the present moment. So with regards to efficacy and effectiveness, we have to remember that efficacy was with regards to trials. And those were hundreds of thousands of people. That's less than 100,000 people. But when it came to effectiveness, it's the real world situation. And that is a very important thing to remember. What are we trying to do with vaccines? Trying to prevent death, hospitalization, ICU care. That's the first thing we want to do. And then secondly, to prevent transmission. We know the studies, all the New England Journal and Lancet studies, It is efficacious. This was the Pfizer study. Then we have the Moderna study. Again, you can see the blue line and the red line, how it diverges one quite early. The blue line is the people they're comparing those getting the placebo as against the vaccine. And these are efficacious vaccines. That is in a clinical trial. This is the AstraZeneca study, which showed that it was again efficacious, the 3 studies, and giving it at 12 weeks when it comes to AstraZeneca was more beneficial than giving it at 4 weeks. And this is why the UK guideline changed quite early with regards to that it should be given at 12 weeks. That's a second dose rather than at 4 weeks. This was a study that was just published in the New England Journal with regards to the J&J vaccine. Again, a very effective vaccine. And I would fully endorse what Prof. Dushanta said, that it's a very effective, very efficacious vaccine, and it's a safe vaccine, although it was held back for a few days in the US and in Europe. So this is again the schematic just showing it. We have a lot of efficacious vaccines which were approved for emergency use or for release to the public. And the question is, the UK government brought in a beautiful sort of process to give the vaccines to as many people as possible. And now we have reached up to 34 million people who have got the vaccine, as in the US. That progress has gone very, very efficiently and very effectively. Now, the question that can be asked is, okay, you're showing they are efficacious, but are they effective in a real world setting? And that is an important question that has to be answered, because if we are going to get this pandemic under control, that's a very important aspect to realize. Are they effective? And they are effective. This is the UK data showing the rapid turn in the number of cases and the number of hospitalizations and the severe disease in the UK. Israel has produced very similar data that were published very recently in those vaccinated and non-vaccinated. And this is a summary of the sort of effectiveness that we have in the real world setting in the US, England, Scotland, and Israel. It's effective vaccines, and they are reducing the number of cases. And that is why we are pushing so many people to get vaccinated as early as possible, so that this pandemic can be controlled. Again, released 2 days ago from the Oxford group, this shows the real world impact of 1 dose of the AstraZeneca vaccine or the Pfizer vaccine. It is very beneficial. It has about 50 or 60% benefit, which increases to about 70 or 90% with the second dose. That's why you must get the second dose if it's a 2-dose vaccine. And this was again showing the antibody responses, that is the second dose will produce a wonderful antibody response if it's a 2-dose vaccine, while the J&J vaccine is a 1-dose vaccine. With regards to the variants, we just have to be careful with the South African variant. This was the study that showed that the neutralization of the South African variant was less with the Pfizer vaccine, as shown in the 4th bar. The similar finding was found in the Moderna vaccine, where again, it was the South African variant that was the tricky variant with regards to the vaccine efficacy. When it came to the Oxford vaccine and the UK variant, it was found to be beneficial in a study done by the Oxford group. It was found to neutralize the virus effectively, but it was not effective in the South African variant. And overall, if we summarize it, the important thing to remember is that the vaccine is less effective in the South African variant as opposed to the UK variant that is going around. There are vaccine breakthrough infections, especially with viruses developing more and more mutations, and that's an area to be watched carefully. And this is a summary slide showing you the effectiveness, real-world effectiveness of the J&J vaccine in the US as opposed to South Africa, where it drops to 52%, and the US it was 74%. So quickly running through the blood clot picture, which Prof. Dushanta has beautifully mentioned. Early on, there was this paper that came up in the American Journal of Hematology of thrombocytopenia following the Pfizer vaccine, about 19 cases published by the New York group, but they did not look for thrombosis, and they were just talking about thrombocytopenia in this group, and it was reversible in most patients, except there was one patient who died. And then subsequently, in the last sort of 3 weeks or so, you had this queue of papers coming in, first from the German and the Norwegian group, where they showed in the New England Journal, where they showed that there was this very, very tiny thrombotic risk with the AstraZeneca vaccine. This was the second study that came from the Norwegian group. And then for the London group, the UCL group, also confirmed it when it came to finding that it was a platelet 4 antibody that was responsible. So this is measured in groups of patients if they develop those appropriate symptoms. However, they are safe, effective vaccines, and the important context to be remembered is that the risk of thrombosis is so much high if you get COVID as opposed to getting the vaccine and getting thrombosis. And that's a very important thing to remember. The CDC, this was mentioned, the CDC paused, the CDC and FDA paused the Johnson & Johnson, but now they have lifted the pause and it should be used. With regards to as allergist immunologists, we have a lot of patients, a lot of questions that come with regards to reactivity to the vaccine, because initially the Pfizer vaccine had some, there were a few people who developed some allergic reactivity, and this would show that the reactivity mechanisms can be quite varied. It can be IgE mechanism, a non-IgE mechanism, or a delayed response, which I won't go into detail, but there can be a wide range of things which we take into account when evaluating this patient. The important components that we should remember in these two vaccines are two components called PEG 2000 and polysorbate 80, and those are found in the different vaccine. Polysorbate is found in the AstraZeneca and the Johnson and the Novavax vaccine. PEG 2000 is found in the 2 mRNA vaccine. They are used for stabilizing the vaccine, and we test for these in the clinic in the appropriate patients. So we have to be remember the different components. This is what we call the Moderna arm or the COVID arm, which is seen around the world. And even in Sri Lanka, there is Prof. Malik will know about this, the different patients. So it can occur across the vaccine, but it mainly occurs with Moderna. That's what they call Moderna arm. So you can have a whole range of skin manifestation post-vaccination, and including urticaria, etc. And we have protocols in which we manage. We advise people how this to be managed. This was a publication in New England Journal showing the typical sort of Moderna arm where you get a delayed type response of this. It does not preclude the patient getting the vaccine, the second dose of the vaccine. You just give it on the other arm, and they have done studies, including biopsies, etc. It shows a delayed type response. So you can get anaphylaxis, which you have to be investigated properly, and then you should use another different vaccine that is severe anaphylaxis. While delayed type responses like the Moderna arm or the COVID arm, you would use a different protocol, and most of the people we are able to give the vaccine by coordinating carefully with the vaccine center. And this is a frequent area that allergists get involved in. Finally, just one more slide with regards to pregnancy, because quite a number of people are talking about pregnancy. Just last week, this publication came from the US group, where they mentioned that the preliminary findings of mRNA vaccine, COVID vaccines, safety in pregnancy, and they found that it's a safe in pregnancy in that group of patients that they had studied. And the present guideline from the UK at the present moment is if the patient is otherwise should be given a COVID vaccine. That is, there are healthcare groups, they have other comorbidities, they are social, working in social care, etc. They should go ahead and get the vaccine. Because the problems occur more later in pregnancy as opposed to early in pregnancy, you can delay till 12 weeks and give it. But the important thing is to give the vaccine, because getting COVID in pregnancy is more dangerous than getting the vaccine during pregnancy, and vaccine will protect the person from getting from the complications of COVID, etc. So that is a current guideline at the moment in the UK and several parts of the world. So what I have done in this quick talk was spoken to you about the innate immune response not working too well in COVID, people getting severe COVID, the antibody and cellular response, which happens after COVID infection, but we want to get this after getting the vaccine. I just touched about the variants because I said some of the vaccine responses can be a bit lower with regards to certain variants, and the important thing is to vaccinate as many people to prevent transmission, to prevent this development of variants. And when disease transmits a lot across millions of people, the chance of variants occurring is very much higher. Spoken to you about blood clots and the PF4 antibody, which you have spoken with Dushanta, reactogenicity. How do we investigate the patients? And this is quite an immunologist area. We get involved quite a lot in this group of patients. Should patients with immune deficiency get the vaccine? Yes, definitely they should get the vaccine. Would they make a response as equivalent to the others? Obviously they would not. So we may need a booster, but they should get the vaccine. They should not be held back because they're immune deficient. And we encourage all patients. Pregnancy, we would tell them to go ahead with the vaccine. If they can wait till over 12 weeks, it's better, but go ahead with the vaccine. If that group of patients otherwise needs the vaccines are not pregnant. That is the present guideline at the present moment. Thank you.
Great. Thank you so much, Suranjit. We all learned a lot about, and this is a constantly evolving story about vaccines. And I would like to reiterate the fact that immune deficiencies, pregnancies, we need to think about the danger of getting COVID more than the danger of the vaccine, as you quite rightly pointed out. Number one. Number two, these issues about blood clots or cerebral venous sinus thrombosis, it's important for us to identify that. So the doctors had to be aware of the fact that this happens between day number 4 and 14, within the first 2 weeks. If you get after the Johnson & Johnson vaccine, or after AstraZeneca vaccine, if you get a severe headache, shortness of breath, leg swelling, or abdominal pain, please go to your doctor and we can run some routine tests, including platelet count, and identify this, diagnose this IT syndrome, vaccine-induced thrombotic thrombocytopenia, right away, because that's crucial in saving their lives. We are not supposed to give heparin to those patients, although they are clotting. We are supposed to give non-heparin anticoagulants. Thank you again. Now we're gonna switch over to the variants. We have a world authority on virology, Prof. Malik Piris, who's a professor of immunology from University of Hong Kong, who has been world famous all this time with SARS. Like he's part of the team who discovered SARS virus, and that's a great honor to Sri Lanka. And he has published immensely on different viruses. Over to you, Professor Piris, to talk about different mutations and the variants.
Thank you. Thank you for inviting me to take part in this meeting, and good evening to you in North America, and good morning to those listening in from Asia. So I'll talk about primarily the question of virus variants. So indeed, I'm trying to address some of the questions that have been sent in by some of the listeners, and I'll try to go through them. So one of the questions is, what is the difference between coronavirus, SARS, and SARS-2? How common is it for the virus to mutate? Is it unusual to see new variants of SARS coronavirus take hold so soon? Are these new viruses more transmissible? Do viruses affect testing accuracy? Do the variants, sorry, it's not vaccines, do the variants affect the virulence of the virus? And are vaccines effective against these variants? So firstly, the first question very briefly, the difference between coronaviruses, SARS and SARS-2. Coronaviruses are a family of viruses which infect a range of animals and cause quite severe disease in some domestic animal species. Until SARS, there were only 2 human coronaviruses that were known. Both caused the common cold, so nobody paid much attention to these coronaviruses until SARS. After SARS, there are 2 more human coronaviruses. So now we have 4 coronaviruses that regularly infect humans. They are present in all parts of the world. But then, of course, we have these very severe coronaviruses, SARS 2003 virus, the MERS virus, and of course, COVID-19. So to address the second question, how common is it for a coronavirus to mutate? So this just shows you schematically images of the coronavirus here. And these are cells infected with the virus. You can see the virus, these small little spherical things budding out of the cell surface. And this is a scanning electron micrograph showing the surface of the cell and viruses coming out of it. So as you know, viruses can only replicate inside living cells. And in the replication process, it has to copy its genome. In the case of coronaviruses, it's an RNA genome. Now, when humans replicate, we also copy our genome, make an exact copy of it, and that is copying DNA to DNA. And that is a very precise process because there is a spell checking or a proofreading mechanism that checks for any mistakes and corrects them. But, and indeed, that is true for any DNA genome, including bacteria. But viruses which have an RNA genome, when they copy themselves in the cell, the so-called proofreading mechanism or the spell checking mechanism is not so effective. So it continues to make errors. So that's why RNA viruses like influenza, HIV, hepatitis C, and of course coronaviruses do have a higher rate of mutation than DNA viruses. But overall, coronaviruses don't mutate as commonly as things like influenza or HIV. Now, most of these mutations are bad for the virus, and they do not survive. Many of the mutations have no real effect. So we see them, and we do use them to track the spread of a virus from who gave the virus to who, that type of thing. But there is no clinical significance. So it's a small minority of mutations that do confer a biological advantage to the virus, and in particularly to survive and become dominant. And these are the ones that we talk about when we talk about variants of interest or variants of concern. And from the virus's point of view, the advantage to the virus is increased transmission, and of course, ability to escape population immunity as it builds up. You have to keep in mind that severity, causing more severe disease, is not necessarily advantageous to the virus. It may happen as a byproduct of increased transmission or evasion of immunity. Now, this is just a family tree showing what I was talking about, the gradual accumulation of mutations. So this is going back to the beginning of COVID-19, beginning of last year, and you can see already diversity appearing, and as the virus spread worldwide, more and more diversity. But most of these really had no biological significance. But then, of course, as you know, more recently, there have been variants, and it was inevitable that this would happen when you have more than 140 million people getting infected. This virus was going to change. Now, there are quite a number of issues because of these variants. So firstly, naming these variants, as you know, the current naming is very confusing, and WHO has been trying to come up with a more simple system, but it's quite challenging because you don't want to stigmatize countries or places of with the naming of these variants. Another point you have to keep in mind is that the place that the first recognition of a variant took place may not be where the mutation arises, because there's a huge discrepancy in the amount of sequencing that is being done. So the only way you can recognize these variants is by sequencing viruses, right, that have been detected. Now, up to now, there have been over 1 million viruses sequenced, but most of them coming from a relatively small number of places. So, for example, beginning of this year, the UK accounted for about 10% of all sequences, and certainly from low middle income countries, the amount of sequencing is very low. So that also biases where a variant may arise and where it will get detected. A second issue, of course, is that once a variant is detected and reported, it is very likely to have already spread beyond that particular place. So that's another reason why it doesn't make sense to stigmatize a particular country or a region. As I said, the important factors is the impact on transmission and escape from immunity. Right, so this is a very simple type of scheme that you can see the original virus, it continued to diversify at its spread. And then the first mutation of significance occurred early last year around May, this thing called D614G. And that had advantage in transmission, and it rapidly became dominant worldwide. So for those of you in Sri Lanka, the Minuwangoda cluster and the second wave of Sri Lanka was associated with the introduction of this D614G variant. But now it's present everywhere, so nobody really talks about it. So then, of course, the virus has continued to diversify, and then you have particular mutations that are of biological significance. So this, for example, is the one first detected in South Africa. Here we have the one first detected in the UK. And interestingly, you can see that a number of these variants of interest have single mutations that are common. And these particularly two mutations is this 501Y mutation. This is the blue box. You see it here, you see it here, you see it here, you see it here. And this is independently arising. It's not that this change occurred in an ancestor and got transmitted to everybody, all the viruses. It is independently arising, the same mutation. And again, we have this mutation E484K. And again, it arises here, 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 here. Again, independently arising. Right. Now, some of them, well, most of the mutations, although mutations can occur everywhere in the genome, and it's a large 30,000 letter genome that you have with coronaviruses, what we are most concerned about because of biological importance is mutations occurring on this spike protein. The spike protein is this protein that sticks out from the surface of the virus, and that is important for the virus to attach to the cell. As you know, it's the ACE2 receptor on the cell. So the spike protein of the virus attaches to this ACE2 receptor on the cell. And therefore, mutations that occur on the spike protein, particularly ones occurring at this part of the spike protein, are particularly going to be biologically significant in terms of changing transmission patterns, efficiency of the binding to the cell, and also because antibodies block this attachment. So also it will affect the effect of antibody neutralization. And what you see here is the spike protein and just two mutations. The 501 you can see right at the top here, and clearly it's going to impact the binding of the virus to the cell. And this is the 484 mutation I talked about. So let us first talk about the so-called B117 mutation, or the so-called the virus variant that was first detected in the UK. Now, I should not be referring to countries because as I explained the reasons why, but equally I realize that for a general audience that if I keep using these strict nomenclature, people will be confused. So forgive me, I will use the country first detected as I talk. So this is the variant that was first detected in the UK. It rapidly became dominant in the UK and has spread worldwide. And indeed, as I understand, this more recent outbreak in Sri Lanka is very likely due to this particular variant which has got introduced in Sri Lanka, but confirmation is awaited. Now this has many mutations, 23 mutations, but a couple in the spike which are of particular importance, this same 50Y, for example. It is at least 50% more transmissible than previous viruses. there is a suggestion of increased severity, but luckily there is no escape from antibody immunity, whether it is from past infection or from vaccination. So that is the good news. Now, one of the deletions that takes place in the spike may result in certain PCRs missing detection, because there are one particular commercial PCR that targets this particular region where this deletion occurs, and then that particular PCR will miss it. And this is what is called the S drop in that particular type of PCR. But generally speaking, you should not be concerned, because most of the PCRs that laboratories use target multiple sites of the genome. So even if you have a miss in one part of the genome, you will catch it elsewhere. But actually this S drop is helpful to particularly pick up the UK variant. And here, I mean, of course, the same thing happened in the UK, but the UK variant, of course, spread to Europe, and very nice studies done in Denmark. So again, you can see that the UK variant was first reported in the UK at the end of last year, but you can see it's already detectable in Denmark at a very low level. This is this red virus, right? And what you see here is the proportion of this variant very rapidly. Within 2 months, it has essentially become the dominant virus in Denmark. So clearly showing that it really outcompetes the other viruses. And in this very nice study where they did in following up more than 5,000 households with primary cases, they looked to see how many secondary transmission takes place in the household. They showed that this B117 variant was 1.5 to 1.7 times more transmissible than the other viruses that were there. A second variant that emerged was in South Africa, near Cape Town, in an area where, in fact, the first wave of COVID-19 in South Africa had a very high attack rate in that population. So it was expected that a fair proportion of that population already should be infected and having antibody. And that is where this particular variant arose. And you can see, again, the same 501 mutation is present, but now you have a new mutation, which I'm showing here in this point here. So in addition to the 50Y. And again, this is arising independently. This is not the UK virus that has come to South Africa. It's independently arising in South Africa. So this also has increased transmission, and this particular variant can reduce the ability of antibody to neutralize. And I will show you data to that later on. But you can again see the efficiency of transmission. So it was first recognized in September, this yellow, very small dot here, and very rapidly by November, over 80% of the viruses that were being detected already have this. So it clearly showing increased transmissibility. And also, as I said, it has this characteristic of being able to partially escape prior immunity and also vaccine immunity. Right. The third important variant of concern arose in Brazil, in particular, in this area called Manaus, which again, in the first wave in Brazil, had a very high attack rate. And antibody studies in the population had shown that more than 50% of the population had been infected, right? But then there was a second wave of infection taking place in a previously infected population. And indeed, it was with one of these variants. You can see again the same 50Y mutation that we talked about in the UK and South Africa. And again, the second mutation that you find in South Africa. Again, this is more transmissible. It has partial ability to escape neutralization from sera from people who have been naturally infected or vaccinated. And there are reinfection cases occurring. And here now you can also see, although these are observational studies, but see evidence of increased case fatality rates in younger adults. What you see here again is once this variant arose in Brazil, very quickly it has become again dominant, again showing the increased transmissibility of the virus compared to the previous viruses. Then, of course, there are a number of variants in the US. I won't go through all of them, but this one first detected in California. Again, you can see the emergence of it's a group of well, two variants, but basically very similar to each other essentially, and you can see them again, certainly in California, increasing very quickly, and then gradually increasing in other parts of the USA. And this has some novel mutations, not the same ones that we saw in the UK, Brazil, and the South African ones. But this is where in the spike protein the mutation is. And what is important is that this is at a site where particular monoclonal antibodies bind. So these are two monoclonal antibodies that I'm sure you'll hear about in the next talk. And this mutation abrogates the effectiveness and binding of some of these therapeutic monoclonal antibodies. And also, if you look at vaccine-induced sera, you can see, for example, this is one particular serum. If you test it against the previous virus, you have quite high levels of neutralization, but you test it against this particular Californian variant, it is markedly reduced. It is not completely gone, but it is markedly reduced. And this is also true with the BioNTech vaccine. And the final variant I will talk about is the variant that has arisen in India. Now they call it the double mutant, but indeed there are more than two mutations, but there are two important mutations. That is true. Here, one is common with the California virus that I talked about. It's the exact same mutation. And the second one is at the same place, the 484, you remember I mentioned it with South Africa and with Brazil, but whereas in those cases it was 484K, now it's a different amino acid, but very likely it is going to have an impact on neutralization. So if you look at the prevalence of this particular variant, if you take it overall of all sequences from India from the beginning, it's only about 3%. But if you look at the samples from April, it's about 50%. And if you look at it from Maharashtra, that is around Bombay, it's about 60%. And again, it appears to be rapidly increasing. So as I said, the biological impact of this is not yet being demonstrated by the Indian colleagues. But as I said, it shares one particular mutation with the Californian virus, which is known to increase transmission and to partially reduce antibody neutralizing activity. And of course, the second mutation, although it's similar to a mutation that is found in Brazil and in South Africa, which reduces neutralization. So it is not yet classified as a variant of concern, but once we have all the information, I suspect it will be. So this is another way of looking at it. And I pointed out that many of these variants have sometimes a dozen mutations, but a few in the spike protein of interest, and a few seem to be coming up over and over again. So obviously the virus is trying to find ways to improve its transmission, escape from the immunity in the population. And it seems that there are just a few ways that the virus can do it. So the 50Y, as I said, has been found in the 117 UK variant, the South African variant, the Brazilian variant, and we know that we can show that it increases efficiency of the virus spike attaching to the cells. So this is probably why it increases transmission. Then there are deletions in parts of the spike. Again, it's found in the UK variant, which seems to alter the spike protein, which may help reduce some antibody activity, although that doesn't really seem to be very significant, at least with this UK virus. Then we have this 484, which is found in the South African and the Brazilian virus, and a similar mutation found in the Indian virus, which seems to help the virus to escape partially the antibody response, and other mutations that help the virus to attach better and increase transmission. So it seems to be so far just a few points where the virus is changing to improve transmission or escape the immunity in the population. And I mean, now there's a lot of data coming out. I think Suranjit showed some data, but again, now this is data showing that this is with the Moderna vaccine, patients, sera, not patients, but the people who are vaccinated with the Moderna vaccine. If you look at the antibody titers with the older virus and with the UK virus, you can see very little change. So the vaccine is quite effective. On the other hand, if you test those same sera against the South African virus, you can see it's not disappeared, the antibody activity, the neutralizing activity, but it is reduced. So as long as you have good antibody responses, you will still have some residual protection, but it is nevertheless somewhat impaired. And very similar data with the BioNTech vaccine. Now, of course, these are antibodies tests in the test tube, but even from the vaccine clinical trials, you do get a hint that this is happening. So for example, the Novavax vaccine trial was done in a number of places, and in the UK site showed 89% efficacy, including against the new UK variant. But in South Africa, the efficacy was only about 60%. And that, of course, in South Africa is the B1351 variant. The J&J vaccine trial, which was done in the US, in Latin America, and in South Africa, you can see in the USA, it was 72% effective, whereas in South Africa, it is 57%. Again, in the face of the South African variant. So there is good news to the extent that it does have some protection, even against this particular variant strain. But of course, it doesn't seem to be as good as against the previous wild type strain. The AstraZeneca vaccine, I think Suranjit mentioned, it seemed to have very low activity against the South African variant, but that particular trial was very underpowered, and it's difficult to know exactly how good or bad it was. Now, very, very briefly, to tell you, I mean, essentially what this study is telling us is that here they have taken blood samples from people infected with the original virus, and you test it against the original virus and the South African virus. As I told you, the neutralizing activity is reduced. Then if you take sera from people who have been infected with the South African virus, and you test it with the South African virus or the original virus, you can see that it is pretty slightly different, but not too bad, right? And similarly, you take sera from people infected with the Brazilian virus, and you test it against the South African virus, it is pretty much similar. So the bottom line is, it seems that the South African virus set of mutations may be protecting against the Brazilian virus, as well as the UK virus, as well as the older virus. So it may be a good candidate for the modifications of the vaccine as we go on. Now, how do these variants arise? As I told you, many of these have not just 2 or 3, they have 23, many mutations. And it's not clear how suddenly this completely multiple mutation viruses arise. And one suspicion is that in immunocompromised patients, we know that infection can go on for a long time. And we know, and there are studies showing that when immunocompromised patients are infected, mutations accumulate. So this may be one way how these variants are emerging. Of course, secondly, when you have a partially immune population, as occurred in Manaus in Brazil, the virus has to find some way to escape. And that is a second pressure that the virus has. And of course, thirdly, we know that the virus does transmit from humans to animals such as mink. And this happened in Denmark, in Netherlands, and in the USA as well. And sometimes you can see the mutations occurring in these mink, which can be transmitted back to humans. So these may be some of the ways that these variants are arising. So let me now summarize. As I told you that a number of these variants, the one from the UK, South Africa, Brazil, California, they do seem to increase virus transmission. This particular 501 mutation appears to enhance binding of the virus spike to the cell receptor. Now, particularly this 484 mutation does have some implications in reducing the neutralizing capacity of sera raised to the older virus, either from natural infection or from vaccination. And as I said, there is evidence that some of the vaccines do have reduced effectiveness, but not complete loss of effectiveness. But one has to say that even in that situation that I talked about in the J&J and the Novavax vaccine in South Africa, although the protection from infection was somewhat less, these people seem to be almost all protected from severe disease. So that is good news. As I mentioned, some of these variants may affect PCR testing, so it's something we have to monitor. But as I mentioned, usually we have multiple targets, so hopefully it should not really result in missing an infected person. It's important to note that these variants still transmit by the same routes, and the social distancing measures still do work. The survival of these variant viruses on surfaces is still the same, not really changed. But because they transmit more efficiently, you really have to work much harder with these social distancing measures to achieve the same level of control. And this is what, for example, the UK showed successfully. Now, of course, when you have millions of infections, and now it's over 140 million humans, you're allowing the virus the opportunity to mutate. So reducing the population of people infected with the virus is the best way to reduce transmission of variants. We will probably, certainly, we will need to update vaccines from time to time to cover these new viral variants, but I do not think it will get to the state of influenza where we have to take vaccines every year. We can discuss this. But just to summarize, I think the best way to control variants is to reduce the numbers of cases globally. So this is the question of, we will not be out of this COVID pandemic until we, control it across the whole world, not in one country or in two. And finally, of course, I think variants are just yet another example of the need to beware complacency. And with that, thank you, and be happy to take questions in due course. Thank you.
Yeah, thank you very much, Dr. Malik Miris. And that was an excellent presentation. But for most of us, I guess the take-home message is that the more you vaccinate, the lesser the number of infection, globally speaking, the lesser the chance of variants, mutations. So the sooner you vaccinate, the better it is. And also, with the second generation vaccine, they will probably have to tweak the vaccine with regard to the mutants, especially 351, the South African variant. So I believe that there's going to be a booster, as both Pfizer and Moderna are working on right now at the end of the year, maybe beginning of our fall, with a tweaked version of Moderna and Pfizer in this country that'll include the South African variant. Now, I would like to move on to my own professors from USC, University of Southern California. He was the chief epidemiologist at USC, Keck School of Medicine, as well as LAC. Now he's the chief epidemiologist at LA County Hospital. And he has published immensely. And he is very well accomplished professor of infectious diseases. And not only that, orthopedic surgery. Prof. Walter, over to you.
Well, thank you very much. It's a honor to be with this distinguished panel and have an opportunity to talk a little bit about the issues of monoclonal antibodies and some thoughts about mitigation of therapy. So let's just talk a moment about monoclonal antibodies and why one would think of that. It's not a new idea, obviously. The idea of passively giving antibodies or protection rather than have the body make its own antibodies really dates back to the 1890s when antibodies were used to treat the disease diphtheria, antibodies that are directed against diphtheria toxin and tetanus. The problem for many years was antibodies were made by the injection of materials or organisms into various animals, and it was very difficult to obtain consistent levels of antibodies in different batches. In 1975, people began to look at fusion of myeloma cell lines with mouse B cells to create things called hybridomas that can produce specific antibodies that are specific to known antigens, for which a group eventually won the Nobel Prize. Human monoclonal antibodies, that is, humanizing the monoclonal antibodies to things made from human cells, has led to an explosion. There are over 120 monoclonal antibodies for various and sundry diseases approved for use in the United States and the EU for a large variety of diseases. But why monoclonal antibodies in COVID-19? Well, there are a number of reasons. If we think toward prevention, severely immunocompromised patients may not be able to produce adequate antibody response with the vaccine alone. We may be able to use monoclonal antibodies to give prophylaxis to exposed people who may not have adequate immunity, and we'll talk about a few of the, at least the beginnings of studies to look at that. And the idea is that it may improve outcome in early disease. In patients with later disease, it's unlikely to actually improve outcome, but in early disease, this may be highly effective. So what is currently available for monoclonal antibodies? Unfortunately, as was mentioned before, these are all almost impossible to pronounce, making it extraordinarily difficult. But we'll start out with the fact that the company Regeneron has made a combination of two monoclonal antibodies, and the Regeneron combination is out and being used. Bamlanivimab was given an FDA emergency use authorization in the United States, but unfortunately that was revoked April 16th of this year, in part because of decreased susceptibility of variants, including some of the variants that are circulating in California here in the United States. When the FDA revoked the emergency use authorization, they did approve the use of a combination of bamlanivimab with another monoclonal antibody. Unfortunately, some of the variants that have been talked about have reduced susceptibility to this in vitro as well, although there's no good data about the clinical implications of that identified reduced in vitro activity against spike protein. The FDA criteria that were approved for use have been mentioned earlier, but it's important to realize that people have to have a positive PCR test or a positive antigen test of some type together with symptoms consistent with COVID-19. For use in the United States, people also have to have a high-risk condition, and they're listed here, a number of high-risk conditions, including age greater than 65, or those who are younger who have a whole variety of diseases. It's approved for patients down to age 12. There are a number of exclusions for the use of monoclonal antibodies, at least at this moment, and that's based on the data that's been generated so far on their efficacy. Patients who are hospitalized or require oxygen therapy are excluded. Those who are under age 12 or have a weight under 40 kilos are also excluded. Well, given that the FDA has gone ahead and given emergency use authorization, what is the evidence for use of these drugs? What do we know about their efficacy? Unfortunately, the evidence for efficacy is somewhat sparse. There's very, very little that has been published as peer-reviewed evidence. Most of the studies are only in abstract form or based on some data in a press release from the sponsor company. One of the challenges of the entire pandemic of COVID is our definition of medical literature has changed from peer-reviewed publications to things put out by news agencies. And so often it's very difficult to actually evaluate some of the evidence. That being said, there are some studies that have been presented in one way or another. The evidence for bamlanivimab and for a combination is primarily based on an abstract presentation of the so-called BLAZE-1 trial, which had over 1,000 patients, was randomized and double-blinded, and the results as reported in the abstract presentation, looking at the endpoint of hospitalization or death by day 29, showed a 5% absolute reduction and a 70% relative risk reduction for hospitalization or death. Again, these were all patients who had tested positive and who were symptomatic but not hospitalized or on oxygen. Unfortunately, for this combination, that's about all the evidence that has yet come out, although obviously there are ongoing trials to look at that. For the Regeneron combination product, on the other hand, there have been a number of trials that have had data presented in one way or another. The only peer-reviewed publication on that is New England Journal of Medicine from early part of this year, which looked at 275 not hospitalized patients who were randomized to either placebo or to the Regeneron combination. They were all symptomatic patients again. The results were that 6% in the placebo group reported at least one medically attended visit after receiving their dose of monoclonal antibody, while only 3% in the drug groups, and there were two groups with different doses of the Regeneron product, only 3% reported one medically attended visit, showing a marked reduction in, one would surmise, severity of illness. There is a much larger unpublished trial of over 4,000 patients, again, double-blind and placebo-controlled, conducted in patients who had had symptoms for less than 7 days and a positive PCR test. The outcome they looked at was hospitalization or death, again, through day 29. The results were that in the drug group, the rate of hospitalization or death was 1%. In the placebo group, it was 3.2%, which is a relative risk reduction of 70%. Unfortunately, there are a number of barriers to giving the monoclonal antibody. In the United States, although monoclonal antibody Regeneron has been available for some time, the uptake of it and the administration of it has been much slower than was anticipated, and many groups are not using the amount that was allocated to them. A number of reasons that this has been hard is the difficulty in identifying appropriate patients early. Many patients wait until later in their symptomatology to come and be tested, and so miss the 7-day window that's suggested. Others, of course, are too ill to receive drug. And then there are the actual challenges to infusion. Each of these requires a 1 hour of infusion and 1 hour of monitoring after. This is a huge problem in many areas. You're bringing in people who are ill with COVID disease, who are presumably highly infectious at that time, and you need a space that's going to provide proper infection prevention precautions for those people to keep them away from the other people who are coming into the clinic or the emergency setting where these patients may be seen. And that takes space. It takes proper infection prevention precautions, and it needs nursing who will be able to cover that full monitoring period. During the past few months in the United States, and particularly in California, where the great surge came of patients, there was simply not nursing staff available to take care of that. Everyone was redirected to taking care of inpatients. As we have seen a surge decrease dramatically here, there is more nursing staff available, but that begs the question of where are you going to be able to do this safely? There need to be special areas set up in order to administer these. So there are many barriers right now to administering it, despite the fact that the data looks very, very positive and important. So what are we going to see in the future? What are people looking for to improve our ability both to treat and to administer this? Well, one question has been, can we give these drugs intramuscularly, as other monoclonal antibodies have, or at least passive immunization has been done in the past? And there is at least one study that is trying to look at that in this group of patients. None of the data has been released. It's still very early in looking at that. But there are other areas that people are looking at. Looking at decreasing the risk of progression to symptoms in patients who are asymptomatic but are infected. There was a trial with 200-some patients who were randomized to either drug, the Regeneron product, or to placebo. These people had tested positive, but had not yet become symptomatic. So they were people usually who tested positive because someone in their family or someone they were in contact with was diagnosed with disease, and then they had come in for a test. The administration of the Regeneron product reduced the risk of progression to symptomatic COVID by 76% after the third day. In those who progressed to symptomatic disease, it shortened the symptoms compared to placebo by 45%. In the drug arm, no patients ended up hospitalized versus 6 of the placebo patients, with approximately 100 people in each group. So very significant benefit in patients who are testing positive, that is infected, but who have not yet progressed to symptomatic disease. The challenge, of course, if this is held up in a larger study, the challenge would be, how do you get to people who are infected but asymptomatic and get them to get monoclonal antibody quickly? There is, of course, a question about people who are early in the course of their disease but sick enough that they may be hospitalized. This has been folded into part of the UK recovery trial, and early results are looking at hospitalized patients on low flow oxygen, but we don't have really those results out yet. There is, however, a study that has come out on the even more interesting question of prophylaxis. Certainly, antibodies or immunoglobulin has been used for years for prophylaxis against certain diseases, such as, of course, hepatitis A. So what about COVID? Well, Regeneron has now a double-blind placebo-controlled trial of around 1,500 patients who were enrolled to receive Regeneron, interestingly given intramuscularly, or a placebo. These were people who lived with a person who tested positive within the last 4 days, but who themselves did not test positive and were asymptomatic. Looking at their risk of getting disease by day 29, there was an 81% risk reduction in the drug group versus the placebo group. The adverse events were actually similar in the two groups. There's a lot of ongoing research then, a lot of questions that are happening as to what we might be able to do. There are challenges, of course, with the questions of new variants and what that might do for monoclonal antibodies, but I think there's a great deal of hope that monoclonal antibodies will provide a very significant part not only of treatment of early patients, but of treatment of exposed asymptomatic patients and hopefully prevention of disease. Thank you all very much.
Thank you so much, Dr. Holtam. As always, you've done wonders to us whenever we host a CME webinar or CME, even a live presentation in the past. So anyway, stay tuned for more questions. But last but not least, we have a panelist from Sri Lanka. He's in charge of the infectious disease hospital, National Institute of Infectious Diseases in Sri Lanka, Dr. Ananda Vijay Vikrama, who's going to talk to us, who is one of my batchmates from Sri Lanka, Colombo Medical Faculty. So we go back a long way. And thank you very much for Ananda for agreeing to a voluntary time and agreeing to present your data about COVID situation in Sri Lanka. Over to you, Ananda.
Thank you, Ditya, and thank you very much for giving me this opportunity. And I wish to thank the foundation for inviting me, and also I consider this as a great privilege to be among these eminent panelists. I'm going to just give an overview of the Sri Lankan situation, which I believe everybody is interested in, being Sri Lankans, whether they are in Sri Lanka or abroad. As we know, we had our first patient in 11th of March, the first local patient diagnosed in Sri Lanka. The first patient was actually a Chinese lady who was diagnosed in late January. And since March, we have been having small outbreaks, but the conditions are pretty much controlled. As of end of August, we had 2,841 cases with 11 deaths. And towards the latter part of August, the case numbers were becoming very low. And all this were due to, there was direct involvement of His Excellency the President in these preventive measures. There was a task force headed by Director General of Health Services and the Commander of Army. Then there were many committees with a lot of political involvement and commitments, and several committees in the Ministry of Health. And the quarantine facilities were handled very efficiently by Sri Lankan Army. That was a very plus point for this control. There were key decisions taken, like the locking down of the country, the closure of airport, then involvement of armed forces and the police, including a state intelligence service for contact tracing. And then there was gradual reopening of the country when the case numbers were going down. Since 17th of March, for about 6 weeks, there was a lockdown in the country with intermittent release. The police was empowered to maintain lockdown measures. During that period, only essential services were maintained, while food and other essential items were delivered to people. By early August, case numbers were limited to small clusters. There was no community spread. The spread in clusters was controlled with active contact tracing and quarantining. We had a relatively big cluster in a Navy garrison and the Kandakadu Rehabilitation Center. However, those were well controlled, and then the mobility restrictions were eased off. So this was the situation towards the latter part of early July, early August rather. Since then, for about 2 months, no cases were reported from the community. And then the day-to-day functions are started with, of course, with restrictions. However, people became complacent. And then we had an outbreak again in mid-October, which continued till about end of January. And with that, we had a relatively large number of cases. With that, we have increased the number of PCR testing, which was done about 20,000 per day. And we had a policy which is quite different to other countries in managing these COVID positive cases and their contacts. All COVID positives, diagnosed COVID positive patients were admitted to selected hospitals, or there were intermediate treatment centers. This was mainly, the idea was mainly to isolate them and prevent the spread of the infection to others, and also monitor them. And if they become hypoxic, then to admit them to higher treatment centers and to treat them properly. In addition, there was a quite active contact tracing using our public health network and the intelligence services. And contacts also were quarantined initially in quarantine centers, but later in their own places. And the contacts were too tested, and that is why I think we found a lot of asymptomatic COVID positive individuals. This is where we manage in my hospital. These are old wards. These are older than 100 years. And I'm sure many of our medical professionals visited this place during their training. This was basically neglected place so many years, but now it's quite active. But we use these old wards, which are well ventilated and well spacious, with getting good sunlight. And I think that is one reason probably we were able to minimize the cross-infection and also the infection of healthcare workers while treating these patients. This is one of our health staff worker and a nurse attending to a patient, and this is seen from my ICU. We have 8 bedded beds in the ICU, and this we had a patient with TB, pleural aspiration is being done. I was doing the pleural aspiration here. So we were doing these other things. And also in these open wards, we were taking the essential precautions to treat this patient. You can see a nurse handing over a packet of meal to a COVID positive patient here. And we were addressing a COVID positive group of patients who were having, they were of course having mild symptoms only. And of course, we did a birthday party for this girl who is in the middle of the slide, preparing the traditional things. And at the same time, we got a lot of support from other well-wishers, including the foundation headed by Dr. Walter Jayasinghe. And thank you very much for that. This slide shows the Air Force people are constructing a isolation ward where we got 16 rooms constructed within 2 weeks. And then we got a donation from engineers from Molotov University, a CT room. And we got a new CT machine from the ward. And then we got another donation with a molecular biology lab with the PCR testing facilities. So we had a lot of improvements with the help of well-wishers, donations, and of course with the help of the Ministry of Health. And then we got a nursing quarters done by a donation from a group in the US. And we had many committees, among which we had a committee on guideline development, which had many meetings. Because of the Zoom system, we were having meetings almost every day or every other day. Initially, we recommended giving hydroxychloroquine based on the limited available evidence, and other antivirals are not recommended. Later, we started using aspirin for high-risk patients as prophylaxis, and then for hypoxic patients, heparin and dexamethasone are being used. We tried using tocilizumab and convalescent plasma for some patients. The numbers are too low to say definite outcome of those. And then at the same time, we made many guidelines regarding, for example, quarantining after exposure and discharge policies from hospital, and so on. And the vaccination was started in Sri Lanka on 29th of January this year. The 2 vaccines have been approved by the Medicines Regulatory Authority in Sri Lanka. Those are AstraZeneca and Sputnik 5 vaccines. We have received, still we were able to get only AstraZeneca vaccine. We were able to get close to 1.2 million doses. And of these, 950,000 doses were given as the first dose, initially to healthcare workers, then the frontliners, and then a part of the population in Colombo. There's a plan to roll out the second dose from the first week of May. There was a delay in giving that because of these reports of thrombocytopenia and clotting following AstraZeneca vaccine. We have had 6 cases with thrombocytopenia and thrombosis following vaccination, who had vaccination. Yeah. And we are awaiting consignments for AstraZeneca vaccine and Sputnik vaccine. Of course, there's a dilemma when these will be received. So there's some gray area here regarding the vaccine. Then the case numbers, as I said, went down by towards the towards February and March, and by early April the numbers are quite low. But then we, as of today, as of yesterday midnight, we have had 100,580 cases with 600 plus deaths. And since the new year, we have seen, we are seeing more cases getting detected and getting admitted to hospitals. And everybody knows we relaxed too much before the new year with a lot of pre-new year shopping and so on, and visiting people, friends, families, and so on. And so that may have contributed to the increasing numbers. And in fact, we recorded the second highest number in Sri Lankan context on 23rd of April, that was day before yesterday, recording about 900 plus cases for a day. And what we see here is we see more symptomatic patients than in the first and the second wave. So we're wondering whether we are at the beginning of the third wave of this epidemic. And other difference we see is more young people are getting affected, and there have been several deaths among young people too. And Professor Nilika Malavige has said that as Professor Piris mentioned, we see S-drops in many PCR results in many of these cases detected. So it could be a new variant, and sequencing is being done at present by Professor Nilika Malavige. I believe the results will be available within 2 to 3 days. So as far as Sri Lanka is concerned, I believe we are at a crucial juncture. And seeing what is happening in India, we are very worried, I must say. So now the media is paying more attention, and a lot of advices are going around for people to take necessary precautions and so on. So I hope those things will work, and the third wave will not be high as it could be. Thank you. That's an overview. I just thought of giving an overview of the present situation.
Thank you so much, Anand. That was so wonderful to hear from you. And I also noticed some of our batchmates in the audience, and I've been going through all the names, and so glad to see your names, at least your names. I don't see your faces other than Anand's face. So very quickly, I'm going to go through some of the questions. Actually, most of the questions were answered already. I personally typed some of the questions, and Prof. Malik already answered some of the questions earmarked on the paper. So, are women taking oral contraceptives more at risk for blood clotting from COVID-19? I think that was addressed. But add to that, I would say if you take a general population, there are about 5 to 10 blood clots every 100,000 per year, every 100,000 normal childbearing age women. And this number is augmented 3 to 4 times with the second generation pill, or 6 to 8 times by a third generation pill. And that is one aspect. So average blood clotting numbers are much higher in that population. But you also have to consider the local numbers from US. We found out about 20% of our hospitalized, especially in ICU patients, there were life-threatening blood clots. So considering those two issues, actually, yes, we do acknowledge blood clotting as a potential problem, but it's all about risk versus benefits, as we discussed before. And I have a question for about the J&J vaccine to Dr. Jayavira. J&J vaccine is 1 dose. It was told, we were told that it was 66% effective in clinical trials. Was it safe to put it out there, or is it all politics?
I think it is safe in general. When vaccines were developed, Tony Fauci and the FDA were happy if we got 50% success rate. So 66% was very reasonable. And in fact, if you look at the US population, it was 72%. So considering that it was 72%, and that, of course, Moderna and BioNTech set a very high standard, but they studied a different population. So I think it was the right thing to do to approve it.
That's right. So add to that, I would say all these vaccines, Moderna, Pfizer, and J&J, pretty much prevents hospitalization and death 100%.
Exactly.
That is the most crucial thing.
Yeah, that's exactly.
Yeah.
I mean, at the end of the day, that's what we are trying to prevent.
Yes. Yeah. So along those lines, J&J vaccine was paused, FDA approved before it was distributed. How could they make such a big error? Please explain the plan to fix it. So again,
I think it wasn't an error. I mean, in the sense that obviously their manufacturing process was in place, and with the COVID, the supply chains are getting disrupted. So I understand, and plus their factory in Baltimore had some problems. So, but overall, everybody tried to do their best, and I think it is what it is.
Yeah, one quick question for Suranjit. I'm pretty sure you went through this in your previous talk, I think. How do viral vector vaccines work? We had 3 viral vector vaccines,
right?
Johnson, AstraZeneca, and Sputnik 5, the Russian vaccine, right?
And the Chinese vaccine too. So there are what it does is say now it takes part of the gene, that's the spike protein gene, it takes a spike protein gene and puts it into another virus that's a harmless virus that causes either a human virus, that is adenovirus 5 or adenovirus 26, or alternatively it puts it into a chimpanzee adenovirus. So the AstraZeneca used a chimpanzee adenovirus, while the J&J vaccine used 26, the adenovirus 20, human adenovirus 26. The Sputnik used adenovirus 5 and 26, while the Chinese vaccine used adenovirus 5. So the reason for using the chimpanzee was certain populations have they have antibodies against human adenovirus, because if you had it's a common cold virus, so you might have antibodies, and therefore the effectiveness of that vaccine may be low, and that is what is happening to the CanSino Chinese vaccine, while the adenovirus 26 is less distributed in the world. So it's the spike protein gene inserted into a viral vector just as a carrier. It just carries that gene into the cell.
That's right. Yeah. I have a question thank you, Suranjit. I have a question for Anand. There's a huge delay in the second dose in Sri Lanka. What is the plan to fix this?
Actually, the initial plan was to give it at the end of 4 weeks, but then there were recommendations that it's better if it is given at the end of 12 weeks. So initially the delay was deliberate, but then there was this clotting thing, thrombosis thing came, and then people were more cautious. And then there were many discussions to see whether to delay it for 16 weeks to see the effects of or the data coming from the UK where the second dose had been given. In fact, I was going to ask Suranjit whether such data is now available. Now the plan is there to start it from first week of May. However, the quantity available is limited. That will be sufficient for the healthcare workers and the frontliners. And at the moment, we don't have any more. We have about 250,000 doses available, kept for the second dose. We are expecting a consignment of the AstraZeneca early May, but of course it is doubtful because of the prevailing situation in India. Then when we get Sputnik, which again will be available hopefully by middle of May, that will be probably a different rollout. I don't think we will be still using it as the second dose for who had AstraZeneca.
Right. So I'm going to ask Suranjit now. So those who have gotten the AstraZeneca vaccine, just the first dose, what is their protection? Now, I can tell you for Pfizer and Moderna, those numbers are out. There's 81% for Pfizer and 80% for Moderna. Efficacy with first dose itself, but we don't know how long it'll last, right, with first dose itself. What about AstraZeneca vaccine?
Yes, so that is about 60%. And that was based on 3 studies, one in England, one in Scotland, and the other one was a community study collecting data from Oxford. And that is coming at about 60 to 70% across those 3 studies. And it improves after 14 days, between 14 days to 28 days. Some study looked at 28 days, some study looked at 14 days. So it's about 60%. And we have to remember, again, with vaccines, I think it's important for everyone that it takes time for the immune response to develop, because it does not develop in one day or 1 or 2 days after the vaccine. And that goes across the board for all types of vaccines that are given. One gives protection, but then the Siren study and actually more the Oxford study showed that the second vaccine, the booster definitely improves protection and antibody levels to a great extent.
Sure. Let me ask Dr. Holtam. You and I get asked this question all the time. People coming from outside, they already received AstraZeneca vaccine. Right now, we were hoping to get AstraZeneca on board. That was a couple of weeks ago, and then came these blood clot issues. So, what would we tell these people who are Americans who already got the vaccine outside, and before entering the country, they already got one vaccine, but they want to complete the series?
Well, it is a real challenge, isn't it? Because there is no data on people doing one vaccine type and then another vaccine type. And we've had the same question of people who do Pfizer and then get Moderna or have a challenge and go the other way around. And there really isn't any good information on what to do. So it's not very easy to give an informed opinion since there's no data.
That's right. It's a bit of a conundrum there, because the longer you wait, the higher the chance of, the higher the risk of developing, if you get a viral infection, that being a mutant form. So of course, mutations are a huge problem nowadays, right?
Conceptually, you would think that getting one and then another shouldn't influence that much your ability to raise an antibody response. That is, they should be working together, but there's just no data.
So what about Dr. Malik theories? How would you answer that? Are you more vulnerable to infections with different mutations with just one dose than both doses?
Yeah, so as I showed you the data, what it shows is that the capacity for neutralization is reduced. But not completely gone. And that is with 2-dose schedules, right? So with a 1 dose, your risk therefore is increased, that your susceptibility to a viral mutant logically would be higher. I mean, just to answer your first question, your earlier question, I think, although there is no recommendation, maybe the thing to do is to give them a shot of Johnson & Johnson, because for a number of reasons, right? So with 1 dose, in theory, even for vaccine, if you want a certificate or whatever, you're still covered, and it's another adenoviral vectored vaccine. So probably that would be the most logical approach. Over.
Yeah, so along those lines, let me ask Dr. Jayavira. So people who will get Johnson & Johnson starting today all over again, because we got the green light again, right? With a warning. Can they take a blood thinner, simple aspirin, for 14 days to prevent blood clots?
Yeah, it comes to the point that, considering that the number of people with thrombocytopenia is so few, that giving a blanket, recommendation would be, maybe not the best thing to do. I think if you do come across people developing thrombocytopenia, and then there may be a position, but I don't think we would be giving everybody aspirin would be advisable in the absence of data. That's my point, that I'm kind of nervous to make it blanket. Everybody gets, perhaps there need to be studies looking at the targeted population, which has the highest risk, which is the women in 18 to 50. And there should be more data collected to answer that question.
Quite rightly so, Dr. Jai, right? We are talking about venous thromboembolism as against arterial thromboembolism. Yeah. Although there are some mixed effects with aspirin. So I don't think it's a big problem taking aspirin, about baby aspirin a day. It's more like a placebo effect more than anything, but something is better than nothing, some people think. Let me ask Suranjit the same question. Would you give aspirin after AstraZeneca vaccine for 14 days, the high risk group?
No. The reason is a very good question. And I think that was asked for me about a week ago. And I did the literature search. I leaned into the literature. It was my friend Ishan D'Souza who asked me the question, because he was due for the second dose. And he said, should I take some aspirin from now on? We are not taking. So I did look at the literature. And then the thing is, you have to remember that it is thrombosis with thrombocytopenia. So there is two things, the thrombosis and thrombocytopenia, and aspirin can affect the platelet count and platelet function. So you have to be careful. And at the present time, as I put down some sort of paragraph on that, there is no evidence. It is recommended, the experts recommend that no studies have been done that you should not give aspirin if the person is not already started or not already on aspirin. If the person is already on aspirin for cardiovascular disease, just continue that, but not for people before or after if you don't have, if there's no reason for getting the aspirin. That is the present consensus, because this question had been asked about a week ago.
Can I just add that there is a small but serious risk of GI bleeding, even taking low-dose aspirin, and that risk is going to be definitively higher than the risk that we're talking about, because the risk of getting thrombocytopenia and clots with the vaccine is extraordinarily low.
Absolutely.
That's right. Thank you. So there's a question for Prof. Malik. There is two people who had vaccination, first dose, after having COVID infection, need a second dose of the vaccine.
So these are people who have had natural infection. So I think that the data is pretty clear on that, at least on the basis of antibody responses, that if you have had natural infection, still giving them a vaccine is advisable, but that one dose is ample. Because in those patients who have been, or people who have been given a second dose, there is no further boost in antibody response, and natural infection followed by one dose of vaccine provides optimal or at least comparable antibody responses to people who are given the non-infected people who are given the 2 doses. Over.
Let me direct the same question to Suranjit, vaccinologist. Would you agree or disagree?
Yeah, so 4 months ago when we started in December, the question was we go and have 2 vaccines. But then the data has started to come out. Some papers, some letters were published in the New England Journal, Flory and Kramer from New York, etc., published, where they found the antibody responses to be quite robust with one dose after natural infection. But one small proviso we must just remember. So at the present moment, we would say, okay, if you have had an infection, definite infection, proven infection, you get 1 dose, so that the vaccine can go to more people. One small proviso is, I think the data from the San Diego group will give us that data, is that what about the T cell response? Because we must remember that antibody response is only one component of an immune response. We might find that the T cell response is better. That is what immune deficient patients, we go and we tell them to get the influenza vaccine, because we don't look for an antibody response there. We look, because patients who are not making antibody, they may be actually making a T cell response. So we have showed the T cell response in patients with immune deficiency in influenza. So that is just one proviso. But at the moment, I fully agree with Prof. Malik's the newer sort of guidance on that. One vaccine is sufficient, but let's see what the data goes with the San Diego group. Yeah.
So, sorry, can I just also add to that? So there is another problem with just giving one dose, and that is about, you know, certificates for travel and things like that. So, you know, whether international travel will accept. So that's a purely practical point. Yeah. Over. Thank you. Yeah.
That's totally different. So thank you for bringing that up, Prof. Malik. But let me ask Anand. Now, Anand is he's the Chief of Infectious Disease, the National Institute of Infectious Disease in Sri Lanka. But he's a little reluctant to use ivermectin. Now, I remember I had about 10,000 patients in this area. And within my group, we managed about 20,000 patients in California, especially with the second wave. We did give ivermectin based on the data, especially the in vitro data that shows 5,000-fold reduction in viral load, whether you buy that or not. There are some studies coming from Brazil and Egypt and some other studies, I think, clearly shows that there's some effect. Ivermectin won the Nobel Prize for a reason in 2015. It's a great anti-inflammatory agent, which has antiviral properties. Of course, we use ivermectin as an antiparasitic agent, but it's a very inexpensive medication with antiviral properties. So let me ask both Anand and Dushyant this question. First to Anand.
Yeah, I agree with you, Deepti, that there are several several studies showing the efficacy of ivermectin in COVID. However, in the recent WHO guideline, they recommended that there's no adequate evidence to use ivermectin, and that is one reason that we are sort of holding on to that. But the more important reason is at the moment, for some reason, ivermectin is not registered in Sri Lanka. Nobody had been interested in getting it into the country. There was no indication, basically. So now some people are working on getting it registered and getting it into the country. Their agents are working on that. In fact, because of this WHO recommendation, and then with the findings of some other studies, we are actually planning for a study on ivermectin. We have in fact applied for ethical approval. Hopefully, we may be able to start within another 2-3 weeks. So that's the current situation here.
Yes, my advice to you, Ananda, is if you use ivermectin, use it in high doses. So 200 to 400 milligrams per kilogram. So that's a pretty high dose. So you have to give about 18 to 20 to 22 milligrams a day for 4 to 5 days. What's your take on that, Dr. Jayavira?
So I am not completely in favor of using ivermectin, because we were going by the evidence-based practice. So the couple of studies we saw, the last publication came from Colombia, the problem was that, as I've mentioned before, they were not adequately powered. So if we are going to use it, you must have a study which is adequately powered. The second thing is that when the COVID started about March last year, I reached out to Merck, that was the manufacturers of ivermectin. When their internal data showed that, as what you said was, you need a high dose. They thought that it was a really high dose of ivermectin to achieve levels that are inhibitory, and it will be kind of difficult to get those levels. So unless you use a nano manufacturing process where you can get a very much higher level into looking at the pharmacokinetics, I have a feeling that you may not get a positive results unless you get very high doses and a large study. You really need a large study. You need to do a good power calculation.
Right. What about Dr. Holton? Have you used ivermectin? Because we are disappointed with remdesivir, right? Because it has such a narrow kind of therapeutic window. So what about at USC, have you used ivermectin?
No, actually, we did not use ivermectin. I will agree, we're disappointed with remdesivir overall. But again, we haven't felt compelled to use ivermectin. I will say, however, we have used not for COVID per se, but we put all of these patients who are coming in with COVID on steroids. And there is a concern that many are coming from strongyloides endemic areas. So I think there is an argument that at least for those patients, ivermectin should be considered, even whether or not it has any good in COVID. There is a concern for strongyloidiasis, hyperinfection.
Yeah, that's a great point, actually. Hyperinfection with gram-negative sepsis, meningitis, and septicemia is common with strongyloiditis in that situation.
So actually, Merck is coming out with a new drug, antiviral, called molnupiravir, which is similar to ivermectin. I'm not sure whether it's similar, but they are developing it, and they ran their phase 1 study, which FDA wanted more information. So they're going back. The company that is manufactured is from Miami. So that's how I know this. So there may be a new antiviral coming for COVID.
Yeah, along with favipiravir, right? Favipiravir never got the approval in the United States for whatever reason, but some countries continue to use favipiravir along, with the treatment protocols that they use for existing treatment protocols. So let me ask one more question from Saranjit now. Remember, there was a controversial thing about AstraZeneca vaccine. If you give half the dose, right, there's better efficacy rates. And nobody could explain that, right?
Yeah.
What about blood clotting? Blood clots. Have anybody looked at that? Are the clots less with half dosing regimes?
Good question. I think Priyadarshini probably asked that question. And so that half dose thing was a manufacturing problem, etc., and measurement problem, etc. However, ultimately it turned out to be it was more to do with the 12 weeks. That it was if you delayed the second dose of 12 weeks, that was where the protection was rather than the half dose. That is why the rollout now, we don't talk about half doses. We just go with the full dose of the AstraZeneca vaccine, both doses, except for under 30 years of age. You would give another alternate vaccine if you've had the first vaccine, because there's a lovely curve that has been sort of plotted by the Imperial and the UCL group of the risk of clotting as against age. And then that only crosses the baseline at the age less than 30. And that was the reason the second dose, very few people less than 30 have got the first dose, if you had a healthcare worker or if you were social care worker. So then you will get some other vaccine, but the full dose you'll get another vaccine, and that is Moderna, that is being targeted at the moment. But in any other person, once you get the first dose of vaccine, the risk and you have not had a clotting defect, still numbers are small. UK has one of the highest numbers of use of AstraZeneca. The clotting risk is extreme. So you would go ahead with AstraZeneca. You would not change it to another vaccine. And if you go with it's the 12 weeks that is important rather than the half dose aspect of that paper, of that original discussion.
Sure. Let me ask Dr. Malik Pires this question. Now, we know that India is experiencing a huge surge, their second wave, and variants like B1618, B1617, and the triple mutant and double mutant forms. Neighboring country Sri Lanka. Would you rather, now we have to be very proactive about these things, right? We know that those mutant forms are going to come to Sri Lanka, but in order to prevent that, should you close the borders with India now?
Yes, so this is, of course, important questions, but purely from a point of view of public health. I think particularly these mutations that are associated with reduction in protection from vaccines. So these are the variants from South Africa, Brazil, and I suspect, data is not there, but I would suspect that is the case, I think it would be sensible to take all measures to reduce the risk of introduction into Sri Lanka, because as far as we know, none of those viruses, those variants are established in Sri Lanka. So I think it would make sense to take all measures to reduce that risk. Over.
What about, I'd like to hear from the horse's mouth, Dr. Ananda Vijayvikrama, who's in the thick of this now. Would you advise your government to close the border? Because it's a given, right? Next few weeks, we are going to get inundated with these mutants at this rate.
Yes, as Professor Malik said, I think it's if you look at the public health point of view, it's easy to give an answer. But then when you consider a country like Sri Lanka, there are a lot of other impacts and ramifications on this due to other economic and other the involvements with India. So it will have to be a political decision taken considering all those aspects. But by personal views, yes. Yeah, as considering the present situation in India and as we are seems to be heading for a third wave, from public health point of view, yes, but then there are many other aspects. Over.
Yes. I have another question on about Sputnik 5. Maybe Suranjit can answer this. Now, Sputnik 5, the main issue from the beginning was the fact that they were actually administering the vaccine without releasing the phase 3 trials, right? And we were very critical of that. Same thing was done by China, right, with some of their vaccines. Without safety data, efficacy data being out, they started injecting the vaccines. But we learned in the end, and this study was published in Lancet, I think about 2 months ago, or 3 months ago, that Sputnik 5 is a great vaccine, 91% or 92% efficacy. How do you, what do you think about that?
Yes, absolutely. I think that's the thing with science and then additional things coming in with regards to sort of political decisions, etc. So when you look at it, on the face of it, the vaccine design looks good. You have two different, you have a boost mechanism, you have one adenovirus, then you come with a second adenovirus. So when you look at it from a design perspective, it's a good vaccine. I mean, it's like the Johnson & Johnson, except that you're given another type of virus after that. But the problem was that in the haste to try and push that vaccine forward without releasing the phase 3 trial, and that is anathema for scientists when things are pushed out without the data, etc. It was said, okay, we have approved it and that can be used. And when you put the efficacy data as published, that's important to remember, in the journals, in clinical trial, Pfizer, Moderna, then it comes to Sputnik, J&J, Astra. So that is the order in which it is. So as you said, it's absolutely so. But that was muddied by even the Chinese vaccine. That's the same process, where the amount of data that is being released are just in drips and drabs, and it's so difficult to find. I wrote a small piece on one of the Chinese vaccines. It was so difficult to find. While if you look at Pfizer, there's so much. I mean, true, it's a lot of lots of press releases initially, but then you get the paper coming after that, right? Oxford AstraZeneca vaccine had a lot of problems in the way they were releasing data. The way they released the data, the 70%, 90%. Then in America, they released the data, and then one day after that, the NIH said, this is wrong. I mean, so there were issues, but at least they could go back and correct it. Absolutely. That 91% is, as it was published, is
that's right. Yeah.
Something to consider.
Thank you, Suranjit. So I have another question for Dr. Holtam. I don't know how long I can go on and on and on until somebody stops me, right? Dr. Holtam, now we are so worried about two things about this COVID-19 vaccines and infections, post-infection, post-vaccine. Reinfection rates, breakthrough infection rates. Reinfection means you've got the infection before, and typically you have T cell and B cell immunity lasting for 6 to 8 to sometimes longer months. But we have had some cases of reinfection. And breakthrough infections after receiving the vaccine. You had, and those are, thank God, those are very mild cases. Most of them are asymptomatic. In fact, there have been 2 studies, one published in Denmark. It's a Denmark study. Reinfection rates are slightly higher in over 65. And then there was another study in UK that shows, 6 months healthcare workers, among the healthcare workers, I think Suranjan knows there's 6 months long immunity with the infection. So what do you think? What's your take on reinfection rates, Dr. Walter?
Well, they're certainly low, but it depends on the patient type. In transplant patients, for example, solid organ transplant patients who are on high levels of immunosuppressives, those are people where the rate appears to be significant and concerning. But for most of them, most people are not seeing many people who have reinfection. And as you mentioned, most of the patients who are being described are patients whose reinfection is either just positivity on test or very, very mild symptomatology.
That's right, yeah. So I personally had several patients who came in after 3-4 months. And one patient came in after 6 months. But in the richest and the country with the best healthcare in the world, I have a hard time getting my genomic sequencing done. Ideally, we have to do, all those patients, we had to do whole genomic sequencing to identify the problem, right? But when you send, you have to go through public health, and when you send those samples, they never come back to us. That's a huge problem. What do you have you experienced the same thing, Dr. Holton?
In fact, we've had problems getting public health in Los Angeles even to do it, because public health is still somewhat tied up with not only all of the consequences of the huge surge we had, but the fact that they're horribly behind in a variety of other diseases that are really a problem right now and spreading. So public health has been stretched extraordinarily thin. So yes, I agree, it's a huge problem because the resources aren't being directed that way.
Right. So after 3 months, 4 months after the first infection, we all ask, you quite rightly pointed out, Dr. Holton, it's the test positivity. We don't take PCR positivity as a reinfection. That is very important to know. So some of my patients who are in ICUs with other complications, we found out that they are still positive. Well, some of them actually had a negative test before that. So it all depends on the kind of test that you use. I believe that some of the tests, PCR tests such as, I think, Cepheids, and I don't want to mention the commercial names. Those are pretty poor now. They were kind of discouraged to be used commercially now, widespread. Academic settings. Do you have any experience with, Dr. Jayavira, any experience with the comparison of the types of PCR tests?
Yes. In many of the studies, the Acula test was not considered as a standard. We had to repeat a PCR. We was actually using a Cepheid or one of the Roche or the Abbott assays. So we were, but regarding the sequencing, we sequence our own samples. So we have our pathology unit would sequence our viruses, and we don't send it out.
Okay. Well, I guess some people are lucky. So, Dr. Malik Piris, what about breakthrough infections? Why do people get breakthrough infections after vaccination?
Well, I mean, it's not surprising. First and foremost, the vaccines are not 100% protective. And secondly, even if they protect against symptomatic disease, you may have, asymptomatic infections coming through. And then, of course, you have the question of variants. So, I mean, I've seen these reports of nursing home outbreaks, for example, in the USA, and I'm not completely clear, how much of that is due to variants and or whether it is matched to the vaccine or not. And of course, what is concerning is not just a breakthrough infection, what is concerning is if there is transmission from that one to others, and that is what seems to be happening in these particular outbreaks in Chicago and in Tennessee, I think. Over.
Yes, thank you. Thank you so much.
The infections, even if you get it, they're not that severe post-vaccine. So the hospitalization and admissions are much less. And another thing is that some of our study patients, what they do is that once you give the vaccine, they go and look for spike protein antibodies. And sometimes they can't detect it. So they get very nervous that I got the vaccine, but I don't have antibodies. Yes. So we try to reassure them, first of all, unless you do the right antibodies, you don't get it. Second is, I think Suranjit and Professor Peiris mentioned that it's not just antibodies. There's a T cell response, in the vaccine. So there is much more protection apart from just the neutralizing antibodies.
Last but not least, I should mention that vaccine gives you protection only after 2 weeks, 2 weeks after the vaccine. Right. So if you let your guard down, if you take your guard down right after the vaccine, chances are you're going to get in trouble. So most of the patients who have come to us, hospitalized and stuff, those are the people who did not have breakthrough infection, but basically they had their first infection within the first 2 weeks. Because within the first 2 weeks, there's no protection. Isn't that so, Suranjit?
Yeah, I mean, it's building up, right? It's the antibody levels are built. It takes time for any vaccine. And the idea was that's absolutely correct. Telling them that just because you got the vaccine today, you can't go and join a sort of music festival or something tomorrow because you won't have that protection. Absolutely.
Yeah. All right. I guess it's 10 o'clock. It's time to, every good thing has to come to an end. Time to sign off. Let me call upon Keishani to take over the proceedings afterwards. We still have 78 guests, participants. That's great.
Thank you, Dr. Deepthi. I didn't mean to send you a text saying how long more, because I felt the doctors are probably getting tired, and Dr. Jayavira is almost 1 o'clock in the morning in Friday. Dr. J and Dr. Aisha are still online. And then Dr. Suranjit has already scolded me for waking him up at 3 a.m. in the morning today. And I promise you, next time we're going to have the UK time in the morning, not early morning, okay? I promise you that. But anyway, standing presentations, very interactive. I mean, it's a lot to absorb, but I'm sure everybody who attended really appreciated the information. I mean, it is really, really important time that we got all the information out clear, and especially about the vaccination. So I thank all of the doctors, and Dr. Deepthi, thank you so much for helping me and the foundation to get this webinar in place. And now I invite the president of the Sri Lanka Foundation, Dr. Dishan Jayasinghe, to convey the vote of thanks. Over to you, Dishan.
Hello. I don't want to take up too much more time. I just want to say thank you. Thank you to all the presenters, all the doctors with us, everyone who's giving enormously important information. And thank you for all the people who attended. We're going to put this on a platform online so other people can take it and download it and look at it and take in what they need to stay safe, because that's our goal, right? To keep everyone healthy. And so thank you all very much. And I hope to do this whenever we need to. So thank you so much.
Thank you, Dr. Dishan. And thank you to everybody. And we'll see you soon.